We are live now.
So good evening, doctors and all the participants and delegates. I, Shuman, on behalf of Shield Healthcare, welcome you all in today's session on markers of on morphology and organized by International Human Embryology Research Academy in association with Shield Healthcare. I would like to welcome all our delegates and all our esteemed faculties. And now it's time to introduce the coordinators for the session. First, Dr. Nidhi Singh, madam. Yeah, Madam did her MBBS, MD Anatomy, DNB Anatomy, MN, and DCE. Madam is presently associated with as an embryologist and scientist level 1, IVF and Reproductive Biology Center, Maulana Azad Medical College, and LNJP Hospital, New Delhi. Next is Ms. Yoshita Tanwar, Madam. Madam did her MSc in Biotechnology, and she's the senior embryologist and laboratory in charge with 8 years of experience in the field of embryology, New Life India Fertility Clinic Private Limited. And Nancy Sharma Brahmavat, Madam, she is the Chief Embryologist and Lab Manager, Department of Reproductive Medicine, IKDRC ITS Hospital, Civil Campus, Ahmedabad, Gujarat. So with this short introduction, I request Nidhi, Madam, to take over the session for further proceedings. Thank you very much.
Good evening to all. I welcome you yet again another session, another webinar. And I would like to start with the statement, understanding leads to independence and to freedom. So I wish you all a happy Independence Day. And on this occasion, let's start with our webinar, which is on the markers of morphology, MOM. And can I have the CVs, please? So we have here our founder, co-founder, and both the co-founders. So I call them as a team of persons who are wise, who have guidance, and who have knowledge. So let's start with the introduction of Dr. Ved Prakash, sir. Sir is the lab director at Southern Fertility and IVF, Delhi NCR. He is president of ACE India and founder of IHERA. He is a member of Virtual Education Committee for SSR and faculty fellowship in ART Amity University, Noida. Sir has been a visiting faculty in MSc ART Mysore University. He has 8 chapters contributed in the textbooks, and the areas of interest for Sir is in vivo fertilization to blastocyst formation and innovation in embryo culture system. Now I'd like to invite Dr. Sanjay Shukla, sir. Sir is lab director at Baheti Hospital, Jaipur, and Shivani IVF and Fertility Center, Jaipur. Sir has done PhD in life sciences. He's working in the field of human reproduction since 1998. Sir has fellowship in biology reproduction from Argentina. He is the vice president of ACE India, the chairman of academic wing of ACE India, and sir is the editor of newsletter of ACE India. Welcome, sir. And now I would like to invite Dr. Chardat Joshi, sir. Sir has done MSc, PhD, and CART from Belgium. He has done post-graduation in life sciences in 1993. Sir has special training in ICSI and IVF from Belgium, for embryo freezing from KK Hospital, Singapore, and has done again special training in laser-assisted hatching from Belgium, in PGD from Germany, and is a doctorate in life sciences in 2018. Sir is the executive member of MPSR chapter and MP IFES chapter. Sir has been the past vice president of ACE Academy, past president of ACE Academy from 2014 to 16, and currently sir is a medical director at Genes India ART Bank. Welcome, sir. And I would like to invite sir to please start our sessions.
Thank you, Nidhi, for such kind introduction. And once again, we are there from IHERA with a new webinar. And it is our constant effort to bring new technology and new knowledge, sharing the knowledge. And that is what is the IHERA is for, sharing the knowledge. So today, we are talking mostly about the markers of morphology. Nowadays, we are seeing more this morphology criteria, because patient, when they get the negative pregnancy, their very basic question is why, when everything was okay, then why the pregnancy is not there. And there are so many things has been already came up to select the best embryo for transfer, to select the best oocyte, to predict the fertilization and all. So today's webinar is themed on this markers of morphology. And I would like to invite our first speaker, Dr. Subhashri. Can I have the CV, please? Okay, she is Associate Professor and Clinical Embryologist, Department of Reproductive Science, Kasturba Medical College, Manipal Academy of Higher Education, Manipal, India, and Masters in Biochemistry from University of Mysore, PhD in Medical Science. And we know the Department of Reproductive Science, Kasturba Medical College, so many scientists and senior scientists are there, and they have come up with a lot of educational activity and new developments in this. So with this, I would like to invite Dr. Subhashri to present her talk. Dr. Subhashri.
Thank you, sir, for the kind introduction. So
Yeah.
I'll take 1 second to share my slide. So I hope you all able to see my slide and hear my voice.
Yes, ma'am.
Okay, thank you. So first of all, good evening, everyone. Thank you for the organizers for giving me this opportunity to present my knowledge regarding the morphology markers of oocyte quality. So why we have to assess the morphology of the oocyte? That is mainly, if you see, so what is the contribution of gametes towards live birth? So if you see this, the picture, so you will understand the contribution of gametes towards the implantation and live birth. So if you see the oocyte or the egg, so it contributes around 70 to 80% towards the live birth compared to the sperm, which is just 10 to 15%. So we need to understand what are the factors which can influence the oocyte quality and how we can assess the oocyte quality in detail before we can optimize the IVF or ICSI techniques in the lab. So when we know that much, the enormous amount of contribution the oocyte is contributing towards the live birth. So not all oocytes give rise to usable embryo. So almost less than 50% of oocytes gets wasted because only a few oocytes have the potency to become blastocysts and give the live birth. So what are the factors which can influence the oocyte quality? So that is important. So one of the major determinant of oocyte quality is age, as you know. So if this figure represents the how the proportion of the good quality oocytes decreases as the age increases, and also meanwhile how the proportion of poor quality oocyte increases as the age increases, that we can understand from this. So age is one of the major determinant of oocyte quality. Next, we know that the proper follicular microenvironment is very much important when oocyte matures in vivo condition. So several factors can influence the follicular microenvironment, such as infertility conditions like PCOS or endometriosis, and the stimulation protocol what we use to trigger the oocyte maturation, and the different oxidative stress conditions which may prevail in the follicular microenvironment can lead to the poor oocyte quality. In one of the study, we have shown that the poor ovarian, the follicular microenvironment in the poor ovarian response patients, they have increased oxidative stress that may lead to the poor embryo outcome that we get in this cohort of patients. So further, even the in vitro manipulations what we use or what we do it in the regular IVF labs, that also may give rise to or may change the oocyte quality. So different manipulations such as in vitro maturation or oocyte denudation, freezing. So all these manipulations have shown to decrease the oocyte quality, or it might have some influence on the oocyte quality. In such one of the study, we have shown that the in vitro mature oocytes are more susceptible to the ICSI conditions compared to the in vivo matured oocytes. So that's how different factors can influence the oocyte quality. So that's why we need to understand the different markers that can give us the information regarding the oocyte quality. Once we do the OPU, so we get the cumulus oocyte complex once we screen the follicular fluid. So that is the first step where we can get some information about the oocyte quality. So usually the literature says that the morphological features of COC can help to determine the oocyte quality. So you can either you may get the mature COC with the expanded cumulus, or the COCs having some compacted cumulus mass. So studies have shown that the mature COCs, when you have mature COCs, so then there is an increased fertilization and pregnancy rate and clinical pregnancy. However, the Istanbul consensus in 2011 has shown that there is little corroborated evidence for predicting the embryo outcome when you do the COC grading or COC morphological assessment. However, it has elucidated that the COC assessment is important tool for troubleshooting whenever we have some issues with the IVF procedures. So what is the next step? So once we have COCs, for ICSI we go for the denudation and then further nuclear maturity assessment. So the nuclear maturity can be assessed by the presence of the polar body in the oocytes. So whenever you have a single polar body in the perivitreal space, that is considered as mature oocyte. When you don't see the polar body, it is M1 oocyte. And when you see the germinal vesicle in the cytoplasm, that is considered as GV oocyte. But just assessing the nuclear maturity is enough to understand the oocyte quality. The answer will be no, because there are challenges when you just assessing the nuclear maturity. Because there might be asynchrony between the cytoplasmic and nuclear maturation. So, so the question is whether the nuclear matured oocyte is really a matured oocyte or not. And also one more aspect is the oocyte aging. So there might be a in vivo aging or in vitro aging. So this process may change the morphological, cellular, and biochemical, molecular, even the epigenetic aspects of the human oocyte. So we have to be very careful. So we cannot just consider nuclear maturity as a single marker of the oocyte quality. So the next, then what is the optimal oocyte morphology? So here in the Istanbul consensus, it has been defined as a spherical structure enclosed by a uniform zona pellucida, and there should be a uniform translucent cytoplasm free of inclusions, and also an appropriate sized polar body. So this is the definition of the optimal oocyte morphology. So whatever deviations you see from this particular morphology, so considered as abnormal, and it might have effect on the oocyte quality. So there are different types of the morphological variations you can see in the oocyte. So that can be classified as extracytoplasmic and intracytoplasmic. So first we'll understand what are the extracytoplasmic variations we see in the oocyte morphology that can be considered as the marker of oocyte quality. So first aspect what we see is the oocyte size. So sometimes we might see the oocytes which are more than 200 microns in diameter. So that is considered as a giant oocyte. So studies have shown that these kind of giant oocytes, which the incidence is almost 0.3% in the regular IVF cycles, they might have abnormal genetic constitution. So they might have triploid or tetraploid conditions. So even the elongated oocytes have a higher incidence of chromosomal abnormality. So this schematic representation, you can see how the giant oocyte can give rise to the abnormal embryos during the fertilization in vitro. So that's why the giant oocytes are never inseminated or injected since they have the abnormal genetic constitution. So since they have they are indicating some of the genetic abnormalities. So oocyte size can be definitely considered as a oocyte quality when we go for the ICSI. So next comes the oocyte shape. So the normal oocyte is spherical in shape, but if you look at the regular IVF cycle, so you might get the other oval shape oocytes also. So the normality of the oocyte shape can be quantified as a roundness index. So usually the roundness index should be 1 for the normal oocytes. As it increases, the shape is considered as oval. So different studies have shown that these type of oocytes have abnormal cleavage pattern also. They show delayed pre-implantation development, but there are no strong evidence to prove that this oocyte shape having some abnormal outcome. Further, the zona pellucida, which is the outermost layer of the oocyte. Here, the oocytes, it's a well-known fact that oocytes in primary follicles and onward are surrounded by zona pellucida, that is generated both by oocytes and enclosing granulosa cells. The Istanbul consensus has shown that there is no specific benefit of measuring zona thickness, which doesn't correlate with any the reproductive outcome, because there is insufficient evidence to prove that the zona pellucida thickness or the coloration have some abnormal outcome. So these effects might be patient specific, and also it has been noted that it is stated that it is better to note down if there is unusual thickness and coloration is observed whenever we go for the ICSI procedure. As an advanced method, the zona pellucida birefringence is being considered as the marker of oocyte quality. The zona pellucida birefringence is can be defined as the refractive index obtained from the polarization and propagation of direction of light using foldscope microscopy. So here you can either get it as high or low birefringence as indicated by these images. So usually uniform high birefringence is correlated with increased blastocyst formation and implantation and pregnancy rate, whereas the low non-uniform distribution of birefringence is correlated with the increased miscarriage rate. However, there are not strong evidence to prove that the ZP birefringence can be considered as a marker of oocyte quality. Next, we'll see how perivitline space varies in different abnormal conditions. So one of the abnormalities you might see is the large perivitline space, or you might see some inclusions in the perivitline space. However, there are limited studies associating these features with the pregnancy and live birth. Hence, there is insufficient evidence to support any prognosis. Therefore, however, like when we do the ICSI, so we just note it down. So if there are any variations in the perivitline space, so that might help in the troubleshooting part. However, we don't usually consider perivitline space as a single marker of oocyte quality. So next comes the polar body, one of the important feature that you can see in the extracytoplasmic condition. So here the extrusion of polar body indicates successful meiotic maturation of the oocytes, but although PB can be used as a marker of quality and even aging status, only the size and fragmentation, the extensive fragmentation of polar body can be associated with the chromosomal condition of the oocytes. So usually it has been suggested that oocytes with abnormally large polar body should not be injected, and also when you have the extensive fragmentation with the polar body, like which are like almost, the fragments are almost similar to the size of the polar body. So in these conditions, we don't go with the injection. So these certain conditions of the polar body may suggest the poor oocyte quality or poor genetic constitution of the oocyte. So this table gives you an overall the extracytoplasmic factors which are being studied with the correlating with the oocyte quality and the outcome, such as zona pellucida, perivitline space, shape, and giantness. And also the first polar body appearance, like whether it's intact, whether it's having proper morphology, or it is having intact or smooth surface, whether it is large or degenerated or it is fragmented. So although we have several extracytoplasmic features that can be marker of the oocyte quality, there is no strong evidence that will correlated with the abnormal outcome. Only the large polar body, oocytes having large polar body, or the fragmented polar body, which is having similar, the fragments having similar polar body like structures, or the giant oocytes. So these oocytes are excluded when we go for the ICSI. So next comes the intracytoplasmic variations in oocyte morphology. So here, one of the important feature what we consider is the smooth endoplasmic reticulum clusters. So under normal conditions, oocyte do contain smooth endoplasmic reticulum vesicles that store and release the calcium ions, which are important for the different physiological processes in the oocyte, and also they are responsible for the cell activation during, or oocyte activation during fertilization. But in some abnormal conditions, what happens? The smooth endoplasmic reticulums, they become aggregated to generate the smooth endoplasmic reticulum clusters, forming a single large aggregate presenting as a round flat and clear disc with a diameter of approximately 10 to 18 micrometer. So they are observed only in M2 oocytes, and usually its incidence is around 6.2 to 9.4% of the cycles. How it is correlated or how it is having relationship the ART outcome, we'll see. So usually when you have SCR clusters, it has been shown that the normal perifertilization activities that involves calcium signaling and mitochondrial bioenergetics are perturbed, and there is no relation to stimulation protocol, age, or endometriosis, but it has an association with the estradiol level, dose of gonadotropins, and duration of these controlled ovarian stimulation. And also it has been associated with early fetal demands, and there is high risk of certain imprinting disorders and fetal anomalies. So oocytes with smooth endoplasmic reticular clusters should not be inseminated. It was suggested in the Istanbul consensus, but in the Vienna consensus, it has been shown that embryos derived from SCR positive oocytes should be given second preference when you are going for the embryo transfer. That is mainly because there were contradictory results which had association between the presence of SCR clusters with the embryo outcome or pregnancy outcome. So next feature or morphological feature that we assess while doing the oocyte selection is the granular cytoplasm, or cytoplasm we can say. So usually the normal oocytes they exhibit uniform, homogeneous fine granules because it is due to the presence of various organelles in the cytoplasm. However, you can see the granularity or granulation at the center of the cytoplasm in these oocytes. So they are considered as abnormal. That might be a manifestation of cytoplasmic immaturity, or may also be associated with the chromosomal abnormalities. However, the exact mechanism how these granulations are appears in the oocyte, it is unknown. However, there is an association with the risk of poor fertilization in the oocytes. However, there are like contradictory evidences when we consider the association between granular cytoplasm with the blastocyst development as well as the pregnancy outcome. So one more important feature what we see is the vacuoles. It's a oocyte vacuolization is a common observation in clinical IVF. So its incidence may be ranging from 3 to 12.4%. So usually you might see small vacuoles which are transparent or fluid filled. So usually the small vacuoles are not considered to be having any consequence on embryo development or the pregnancy outcome. However, extremely large cytoplasmic vacuoles have been associated with the abnormal spindle because it has been shown that it can physically displace the M2 oocyte or M2 spindle from its usual polar position, and thus might cause the fertilization failure. So usually it has been shown that the blastocyst formation of vacuolated oocyte is up to 12.5%, so which is very low compared to the normal oocyte. So the next feature what we see is the cytoplasmic inclusions. They are very small inclusions that you can see in the cytoplasm. However, there is no correlation detected between the cytoplasmic inclusions and the developmental parameter. So it may not be a great marker of oocyte quality. So next comes the retractile body, one of the important the morphological feature which we observe in the oocytes. So usually they contain mixture of lipids and dense granule materials. So usually the studies have shown that the retractile bodies which are measuring less than 5 micrometer may not have any consequences. However, when they are large, when they are more than 5 micrometer, they are associated with the poor fertilization and blastocyst formation. However, we have very less limited studies that have looked into this aspect. So next, due to some advancement in the technology, so nowadays people are having pore scope microscopy, so they are able to visualize the meiotic spindle of the oocyte. So here, usually studies have looked into the visualization of the meiotic spindle or measuring the length of the meiotic spindles that has been examined to determine predict the early development related features. So usually visualization of spindles have been associated with higher zona pellucida birefringence or fertilization rate, progression to the blastocyst stage or increased implantation. However, with comparing the other features, here also we have contradictory evidence as different softwares or different technologies have been used to visualize the meiotic spindle. So here you can get the summary of different features which has been used to analyze or view the meiotic spindle that has been shown to have some effect on the reproductive outcome. So overall, if you see the dysmorphisms in the oocytes, so it might have been acquired during early maturation or late maturation. So if it is acquired during early maturation, it might be because of aneuploidies that might get manifested as the giant oocytes or having central granulation or some meiotic spindle defects. If it is of late maturation defects, then it might be because of the developmental failure. So you might see the aggregation of smooth endoplasmic reticulum and vacuolization. So these are the basic morphological features what we understand under light microscopy. But with the advance, so we have a new method, the artificial intelligence in reproductive medicine field also. So this is one of the very beautiful study where they are incorporated the artificial intelligence to understand the different aspects of the oocyte morphology, whether the artificial intelligence, whether it will be able to identify the different morphological features of the oocyte. So here you can see the software is able to identify the different features of the oocytes like granulation or the regeneration or the polar body, how it is. So like that, so the software is trying to differentiate the different morphological aspects of the oocytes. So here you can see the results where you can see that the artificial intelligence or deep learning method, what they have incorporated in the study, it could predict the, or it can grab where you have a clear cytoplasm with having 99% efficiency, and also like it could detect polar body area, and it could get perimeter space and also zona pellucida. However, it failed to detect the cumulus cells which are present in the zona pellucida. So this is how you can incorporate the new developments in order to understand the oocyte quality. However, considering one factor, it may not be sufficient. So usually better to incorporate different factors which can give us the prediction of oocyte developmental competence or embryo implantation potential. So we have tried using the oocyte and embryo morphology, where we could get around 90% of accuracy while predicting the embryo implantation potential. Hence, we wanted to understand whether incorporation of metabolomics of the embryo can add the accuracy to the implantation potential of the embryo. So here when we combined the oocyte embryo morphology along with the embryo methodology, you can see that there is the 100% accuracy in predicting the embryo implantation potential. Hence, the adaptation into newer techniques may give us the better idea of the oocyte quality and its developmental competition. So with this, I would like to summarize my today's topic. So if you see the lecture, there is no consensus on which of the oocyte morphological features provides the best marker of oocyte quality. Instead of going for single parameters, multiple morphological parameters can be a good method of predicting the oocytes having higher potential for producing competent early embryos. So right now we have a lack of well-designed RCTs, the randomized control trials on the morphological markers of oocyte quality. With the advancements in the IVF field, incorporation of new technologies such as full scope microscopy may give more information on the oocyte quality. Also, the image-based, AI-based algorithms may also provide better oocyte selection methods. With this, I would like to acknowledge my mentor, Professor Dr. Satish Kumar Adiga, and Department of Reproductive Science. Last but not the least, I would like to thank organizers for giving me this opportunity. Thank you for your attention.
Thank you, Dr. Subhashri. Such a nice and elaborate talk, and it is well explained that what are the markers we should be considering. But I have few basic questions here. This is what we are talking about is all an advanced stages, which is may not be available at a center level, because you are an organization, so you have research center, research facilities, so you have all of these instruments. So my question is, what, being an embryologist, what one embryologist's basic thing should look towards oocyte to assess its maturity? Basic thing. And the second question what I wanted to ask you, because this has been asked to me by many people, how will you differentiate between a fragment or a second polar body? Because you know the second polar body extrusion means it's a post-mature oocyte and you may not get the fertilization in it. So how to differentiate? Do you have any points on this?
For your first question, sir, I would like to say, since there is no proper evidence which can suggest that the oocyte morphology will have some abnormal outcomes, so it is really difficult to say which marker may give us the better prediction of the oocyte quality. That's why, like, we consider different features, and and if there is like multiple abnormalities, that might the criteria for the oocyte deselection while doing ICSI. For your so what I wanted to convey is that maybe with the advanced techniques we should focus on, and we should optimize them to incorporate for the assessment of oocyte quality. So that will be our future. So that's why I presented the artificial intelligence, how it can help in the oocyte quality assessment. For your second question regarding the polar body assessment, so usually if it is a extruded polar body, in like second extruded polar body, I think the polar body size will be similar. So that is an indication. If it is fragmented, sometimes you might see the size is very smaller compared to the first polar body. And sometimes you might also see that the fragmented polar bodies are of similar size and they are distributed all over the perivitline space. So this is an again the marker where you can deselect the oocytes. So this is my experience with my like embryology field.
Yeah. Thank you. And another one question was there about this thick zona. We have seen
Yes,
many
sir.
times thick zona oocytes are there, and
Yes, sir.
while performing XC, we find a bit of resistance also during injection.
Yes.
And sometimes, even if we perform a normal IVF, there is failed fertilization with these oocytes. So my
Yes, sir.
question is it means in your talk, you said that there is no correlation or any evidence about this zona pellucida thickness. So what
Yes,
is
sir.
your experience? What you feel in your day-to-day practice come across when such situation? So what may be the reason for that? Is it zona
Okay.
only, or maybe there is some other factors also involved with this?
Oh, okay, sir. Like usually, like zona pellucida thickness will come to know only when the oocytes are denuded. So if we have done already IVF, I don't think like we'll be able to do anything. So definitely, if there is thick zona, sperm might it might face some difficulties to penetrate the zona. So thereby we might see the fertilization failure. But in case of ICSI, I think even if there is like thick zona pellucida, we should inject and see like whether we'll get the embryos. I think it should not be a criteria to deselect the oocytes when we do the ICSI. So definitely, like maybe once we have embryos or blastocysts, depending on the zona pellucida thickness, we can perform laser-assisted hatching, and we can try to increase the chance of implantation.
Okay.
So we have
Thank
few
you.
questions in our question and answers.
Yeah. That was I was just about to ask you. Please read that.
Yeah, so, I read, which is in continuation to Sir's question. What is your experience about the markers which has a bad prognosis? In your experience, which marker do you think has the most bad prognosis? Dr. Shubhashay.
Okay. So usually like SER clusters and vacuoles, these are few like when they are like very large. These are some of the features we can say it might have some abnormal outcomes. However, like if they are small, you can try avoiding puncturing them when you are doing ICSI, so that the sperm gets an environment which can support the fertilization. Otherwise, if you puncture them, definitely you might expect poor fertilization. So that's why we need to avoid area when you go for ICSI, having SCR granulation or vacuums.
Okay. There's a statement. I believe that the roundness index, that is RI, as proposed by Richter and mentioned by you, pertains not to the shape of the oocyte, but the shape of the ICM in the blastocyst grading. kindly elaborate.
So it has been like used for already the whatever I have mentioned, Richter, that is used for blastocyst morphology, definitely. But it has been also evaluated with the oocyte quality also. But as I mentioned, there is no proper evidence to show that the roundness of the oocyte is having some effect on the outcome. But definitely, some of the studies have shown that if you have ovoid oocytes, so that might have an effect on the cleavage as well as there might be delay in the embryo development.
Okay, I'll just take one more last question.
Okay.
What is the reason for dysmorphic oocytes?
Dysmorphic oocyte is nothing but the whatever the variations I have mentioned in the lecture. If you have normal, that is called normal oocyte, normal morphology, whatever I have defined. So whatever the variations you see from the normal, they are considered as dysmorphic. So for some of the dysmorphic oocytes, we don't have an explanation how it gets arises in the oocyte. For some, we have, as I mentioned, it might be from the early maturation stage or from the late maturation stage. If it is early maturation stage, it is due to the aneuploidies, which we acquired during the folliculogenesis. So here, basically, you might come across like those aneuploidies are manifested as the giant oocytes or having the central granulation in the oocytes, whereas if it gets acquired during late maturation process, then it is manifested as the smooth endoplasmic reticulum or vacuoles. So that can be seen in while we do the oocyte morphological assessment.
Okay, ma'am,
Yeah.
because of paucity of time, we cannot answer all the question live, so we'll be taking them separately. So
Okay.
I would like to, ma'am, could you stop the screen sharing?
Sure,
And
sure.
we would like to continue, and I would invite Yoshita to please take over.
Thank you, Nidhi. Let's forward for next lecture. I will invite Dr. Ved Prakash. Sir, uh, please, please open the slide. Uh, and Sir is a lab director at Southern Fertility Clinic and the co-founder of iHera. Welcome, sir.
Hello, thank you, Yoshita. So, our next lecture will be on oocyte markers and their effect on blastocyst formation. So, for that, Dr. Bindu Chumeto is here. She is IVF scientist and consultant clinical embryologist, MSc, MPhil, PhD biochemistry, MSc clinical embryology, and joint secretary IFS Vidarbh chapter. Presented 18 original research paper as first author and 45 as co-author at ASHRAE, and won best paper in travel training award at ASRM 230, and published a original research paper in international peer-reviewed journal, reviewer of journals Reproductive Biology and Endocrinology and Journal of Assisted Reproduction and Genetics, contributed 14 chapters to national international books on infertility, and her major thrust area of research, follicular fluid metabolomics, endometrial receptivity, reproductive endocrinology, and she is a member of ASHRAE, ASRM, IFSSR, ACE, and NOGS. Over to Dr. Bindu Chubota.
Thank you so much for this introduction, and I must congratulate the organizers first and foremost for always coming up with such beautiful topics and themes for your webinars, and to devote an entire webinar to oocyte morphology is really commendable. And in a time when we are moving towards time lapse and artificial intelligence, to focus on the morphological aspects of the oocyte is, I believe, of utmost importance. It gives a lot of idea of how the embryo will develop further. So thank you so much for giving me this opportunity, and I hope you can see my slide.
Yes, ma'am.
Okay. So, first of all, I would like to congratulate Dr. Shubhashri for this wonderful lecture that she just gave. I don't know whether I should be thankful or not, because there's going to be quite an overlap. I mean, whether it is a good thing or not, but for the audience, there's going to be quite an overlap between what she has just said and what I'm going to say. But the only thing is, I will focus more on the blastocyst formation rate. So, the topic today is oocyte morphology and the parameters that predict blastocyst formation. By this, I presume that it was only the oocyte morphological parameters that I had to take into consideration, and I have done just that. Okay, so as Dr. Shubhashri has already said, that oocyte is the most challenging and the most important factor in IVF success, and as was said as early as in the 16th century, that oocyte is everything, because everything comes from the egg, ex ovo omnia. So whether it is spontaneous or assisted reproduction, it all depends on the oocyte quality. It is a prerequisite for obtaining healthy embryos, and many of the cellular and molecular mechanisms required for fertilization and early embryo development are inherent to the oocyte. And of course, the mitochondrial DNA comes only from the oocyte. So, oocyte is such an important criteria for assessment, and it can give us an idea about so many different aspects of the embryo development. And as has been rightly said, when we talk oocyte morphology, apart from the inherent genetic factors or some unexplained causes, the main factors that influence the oocyte quality and the oocyte morphology is the clinical aspects, which include the stimulation protocol that is used, whether it is the short protocol, long protocol, agonist, antagonist, the time, the brand, and the dose of gonadotropins used, the number of days of stimulation, the time of trigger, and the timing of oocyte pickup. Here I have tried to depict how the clinician is there devising her stimulation protocol and trying to offer us embryologists the eggs, and there's the embryologist who's trying to see whether the clinician is giving us the right kind of eggs or not to question, of course, but to just ensure that our job is made easier in the laboratory. And of course, apart from that, there are the patient parameters like the age, PCOS, endometriosis, tuberculosis, and the abdominal pox, which is in India at least, this is a huge cause of oocyte morphological defects as well, apart from age, PCOS, and endometriosis. Endometriosis more so because of the ROS that is generated, and Dr. Shubhashri has already mentioned about these parameters. So, we talk of the good oocyte, the bad oocyte. The good oocyte otherwise may give us an omelette, the bad oocyte may just wither away. So, in embryology or in IVF, we talk of good oocytes in the terms that it gives us a very good blastocyst, and a bad oocyte which does not lead us to a good
Excuse me,
quality.
ma'am. Excuse me, ma'am. There is slight cracking of your voice. So,
Okay.
so little disturbance. So just, please check, ma'am.
Yeah, just a moment, please.
Yeah. Sorry, ma'am. Sorry. Thank you.
Yeah, that's okay. Can you hear now?
Yes, ma'am. It's clear.
Is it better?
Yes, ma'am.
Okay. So I hope I was audible even otherwise till now. Okay. So when we talk of the good oocyte and the bad oocyte, it is the oocyte which leads us to a good quality blastocyst, or it does not form a blastocyst at all. Forget the pregnancy rates therefore. So the normal oocyte morphology, I need not go into the details. A good morphology oocyte is one that has a uniform zona, polar body, the meiotic spindle placed rightly just below or near the polar body, and of course the shape of the oocyte, the cumulus complex present around the zone, the thickness of the zona, and so on and so forth, and the presence of the perivitelline space. So this is how a normal oocyte morphology should be theoretically. But what we see in the lab is not this picture, of course. So what do we see? So oocyte morphology is a reflection of its maturation status, which includes the nuclear as well as the cytoplasmic maturation. And this occurs concomitantly in vivo, but when we are talking of IVF, there is a lag in the cytoplasmic maturation vis-a-vis the nuclear maturation. And therefore, why all the stimulation protocols and other aspects affect the oocyte morphology is because of this lag in the cytoplasmic and nuclear maturation. Also, a nuclear maturation is not restricted just to the presence of a polar body. So, it's not just a single polar body, but also the placement of the meiotic spindle, which is really what nuclear maturation is all about. So, what we see in the laboratory, what is the morphological, how do we grade the morphology of the oocyte? When we are talking of conventional oocyte, conventional insemination, the only thing that we see is the COC complex. So, the presence of the corona radiata cells and the zona, if at all, that is the only thing that we can see. But based on this looseness of the cumulus cells and how we visualize this under the microscope tells us about roughly about the maturity state of the oocyte. So this is what you see on the left is a normal morphology oocyte as observed under the microscope just on the basis of the COC complex. And similarly, which appears like this. So where the COC complex is too tight, then it is very little, the cumulus mass around the oocyte is very less, or it is too tight and elongated. So all this signify that the maturity status of the oocyte is not yet achieved. Forget the cytoplasmic maturation, even the nuclear maturation may not have been attained. But this is just that we can visualize morphologically in terms of conventional insemination. So before we move further now, what we also need to know is that the cumulus oocyte complex, the COC complex, why is it important? We should understand how it acts to understand why it affects the morphology. And as you can see that there is a complete mobilization of fatty acids and catabolism in the COC complex, and all these biochemical reactions and pathways help in the maturation of the oocyte. So why the COC complex is also important. Just the morphology that you see under conventional insemination is also extremely important because it is going to manifest itself in terms of the maturation stage. So also how the cumulus cells are placed, how the gap junctions between them help in the transfer of metabolites in and out of the cell, that is the oocyte, and how various cytoplasmic organelles are involved, be it the mitochondria, the endoplasmic reticulum, and so on. So the cumulus mass surrounding the oocyte, the zona, thickness of the zona, and the cellular organelles inside the cytoplasm, present in the cytoplasm of the oocyte, they all help in the maturation of the oocyte. And therefore, any problem not only within the cytoplasm but also the extracellular mass that you talk of, the cumulus and the thickness of the zona, may have its bearing on the oocyte morphology and the embryo developmental potential. So you can see that how the lipid metabolism occurred, then the glucose metabolism, how it is influenced by the presence of the COC complex. Now coming to what is the normal morphology and what is the dysmorphism, and as this is visualized in case of ICSI when you have denuded the oocytes. So I will not go into the detail, I will take each of these aspects individually, but then as you can see all these are the oocytes which are not normal. Dysmorphic, that is abnormal oocytes that we see after denudation before we do ICSI, whether it is a giant polar body, whether it is a central granulation, whether it is a large perivitelline space, the presence of vacuoles, the smooth endoplasmic reticulum, the inclusions, and so on and so forth. So what is normal oocyte? This is how a normal oocyte looks like or should look like: an ovoid, translucent, as Dr. Shubhashri has already said, the presence of one solid, clear polar body, not a fragmented one, a requisite amount of perivitelline space, and a proper thickness of the zona. This is what a normal morphology oocyte is all about. So, in oocyte dysmorphism, what we see is all these things, as I'll be discussing further. Now, there's this very beautiful paper that came out in 2020 that discussed about the selection of the competent oocytes by morphological criteria for assisted reproductive technologies. And they tried to take into consideration every single aspect of the oocyte right from the presence of the blood. And surprisingly, I mean, we know that the blood may hamper, presence of blood during OPU that we get may hamper, but then what exactly happens is noted by several studies from Thomas Ebner's group to Daya et al. And I mean, several studies carried out by Ebner's group. So presence of clot decreases not only the number of harvested oocytes and oocyte quality and fertilization rate, but also the blastocyst formation rate. So if there is a oocyte that you have tried to retrieve from a clot, then understand that okay, you may have got an extra oocyte, but it may hamper the blastocyst formation rate. Apart from that, there is higher apoptosis rate. The presence of expanded or fluffy cumulus cells and expanded corona cells increase the chances of fertilization and also the blastocyst formation rate, because as we have seen, it is the cumulus mass through which the maturity status as also the exchange of the metabolized nutrients takes place. So yes, the presence of adequate and properly defined cumulus mass is important as far as embryo development is concerned. So now talking about some extra cytoplasmic parameters of human oocytes which are related to the zona pellucida. So everyone talks of a thin zona pellucida. So I would like to say here, although I have mentioned a thin and a thick zona pellucida, I would like to say a normal optimal zona, a thin zona and a thick zona, because none of the studies have tried to include a very thin zona on the embryo development and blastocyst formation rate. So this is the zona pellucida. It is written thin, but I would like to say an optimal, this one, the first figure that you see, an optimal regular zona of a uniform thickness that increases the chances of fertilization. If it is a very thick zona, then the oocyte development, so also the embryo quality leading to the blastocyst formation is hampered because of the presence of a thick zona. Apart from that, what I would like to say in the laboratory practice, when we come across zona which is extremely thin, it becomes difficult to even hold the oocyte when doing ICSI, because we fear that the oocyte should not be damaged in the process. So yes, we come across very thin zona, and that zona, such a zona usually then also is accompanied by a large perivitelline space. Not only a large perivitelline space, but there could be the presence of a septum. And how does it manifest itself in terms of embryo development and blastocyst formation is that look at the embryo quality that is formed here. It is, yes, it has cleaved and it is showing around 7 to 8 cells, all right. But look at the thickness of the zona, or rather how thin it has become. And such embryos have a very poor prognosis for blastocyst formation, because as I had mentioned earlier, it is the zona pellucida also, apart from the cumulus cells, which is responsible for the formation of gap junctions and the exchange of nutrients from the medium, and I mean the exchange of nutrients across the membrane. So in such cases, such embryos may arrest or may not form a very good blastocyst when the zona is too thin. So yes, most of the papers do not mention a very thin zona, but this is what I have come across in my own laboratory practice. If the zona is extremely thin like this, then it could be a very bad prognostic factor for blastocyst formation. So apart from this, the birefringence of the zona, again here a lot of work has been done. And Dr. Subhashri has already mentioned. So apart from that, there is the perivitelline space, a large perivitelline space around the oocyte shows decreased fertilization rate, decreased embryo quality, and but then there is again another paper which contradicts, saying that a large perivitelline space may enhance the embryo quality. Well, personally, I feel the large perivitelline space at least is not a good predictive factor for good quality embryo. Then apart from that, the presence of a normal granulation in the oocyte is indicative of a good mature oocyte and lower implantation and pregnancy rate. So presence of granules, if it is an optimal granulation, uniform granulation, it is a good prognostic factor, but then presence of more granulation, as we will see later also, so it is not a good factor for implantation and pregnancy rates. The shape, the ovoid shape, now this depends when we say ovoid shape of the oocyte, whether we are talking of the ooplasm or whether we are talking of the zona pellucida. So usually when we say an ovoid shape, it is usually the zona which is elongated and the ooplasm is spherical or normal in shape. So this is this may lead to a delayed blastocyst formation, but blastocyst formation rate per se is not hampered. Then, like I said, very thin zona pellucida is a poor prognostic factor for blastocyst formation, and high birefringence, that is the visualization of the zona, it increases the fertilization rate, embryo quality, the blastocyst formation rate as well as implantation rates. Okay, so now coming to another factor which is called as the giant oocyte. Now here on the screen at the moment you will not be able to differentiate, but then we all know what a giant oocyte looks like. So a giant which is more than 200 microns in size, and in such cases mostly it is the chromosomal complement that is affected. There are various studies which have tried to associate the size of the oocyte with the blastocyst formation and the implantation outcomes. And it has been said that they may not really affect the fertilization potential, but then it has been advised that such oocytes may better not be selected if there are other options available. Now coming to the other morphological parameters that may affect the blastocyst formation rate, the potential outcomes of morphological changes in the first polar body of the human oocytes. So as depicted in this first picture here, normal oocyte, good morphology oocyte with optimal zona pellucida, the requisite perivitalized space and the polar body. But then if the polar body is giant, so intact polar body increases fertilization rate, embryo quality and increases the blastocyst quality as well as the available embryo number. It also increases the implantation rates and pregnancy rates, and if it is a large polar body, then there is a decreased viability, decreased fertilization rate, decreased cleavage and embryo quality, and so on. So the blastocyst formation rate, and it may also lead to degeneration of the oocyte. Then apart from that, the presence of fragmented polar body. Sometimes you see several little fragments. You cannot make out how to really orient the oocyte for ICSI. So a fragmented polar body is not a good prognostic factor for the blastocyst formation. Now what I feel is the fragmented polar body could be because the nuclear maturation is not yet complete. So although you can see a polar body, but then still the meiotic spindle probably has not been placed properly, and therefore you can see a fragmented polar body. This is just, no scientific evidence yet to say, but from practice that the nuclear maturation is not yet complete. So therefore you see in fragmented polar bodies, you also see a cytoplasm which is very granular. Apart from that, now when we talk of lack of proper maturation, nuclear maturation, so although the polar body is present, the meiotic spindle, if it is displaced, so in that case also you see, apart from the polar body which is either fragmented or which looks porous or which may sometimes appear as vacuolated polar body, and apart from that the cytoplasm is very flat. The oocyte appears very flat and there is no elasticity to the oocyte. So such a polar body, such a oocyte probably has a meiotic spindle which is displaced and which is not a good prognostic factor for blastocyst formation. So if you visualize as is seen in pulse scope. Otherwise, you can, without the pulse scope, of course, you cannot see the meiotic spindle. But if it is visualized, then it is a good prognostic factor for fertilization rate as well as blastocyst formation and pregnancy rates as well. Longer spindle length is also concomitant with increased fertilization and blastocyst formation rate. Then apart from that, if it is a misaligned meiotic spindle, there may be fertilization defects. And normally appearing spindles, of course, have good quality blastocysts, and not only good quality blastocysts but euplite blastocyst number. So that is why I said that the nuclear maturation is not yet complete if the meiotic spindle has been displaced, and therefore the chances of chromosomal abnormalities will rise even if fertilization has occurred. So oocytes will be, but without a birefringent spindle, may still be at telophase 1 or prometaphase 1 stage. Thus, precocious ICSI in prometaphase 1 oocytes with unaligned chromosomes may be one reason why oocytes without a birefringent metaphase 2 spindle have a significantly worse prognosis for blastocyst formation. Now coming to the cytoplasmic changes that may potentially harm the prospects of having a good quality blastocyst. So the presence of vacuoles, there may be just one or two smaller vacuoles, or there may be several vacuoles. So presence of vacuoles, as has been suggested, that may be because of high levels of serum estradiol, and therefore we may extrapolate it to say that in case of PCS women, where the number of follicles and oocytes are more and E2 levels are high, so in such cases we may see more vacuolation, and the oocyte cryosurvival rates are less in such cases if there are vacuolated oocytes. They therefore also are not a good factor, prognostic factor for the blastocyst formation rate, and even if a blastocyst is formed, there may be reduced hatching of the zona pellucida in case of oocytes where there is a high degree of vacuolation. So, and of course, therefore, the pregnancy rates will also be hampered. So, Van Welcome suggested that large vacuoles may displace the metaphase 2 spindle from its polar position. And interestingly, no fertilization above a vacuole size of 14 microns has occurred in this study, particular study by Van Welcome. So, yes, a high degree of vacuolation or vacuoles of a very big size, 14 microns and above, may hamper the fertilization as well as blastocyst formation rate and therefore the clinical outcomes. Then presence of granulation, again, so as can be seen here in the second figure, there is a lot of central granulation. So this signifies in terms of maturation that the cytoplasmic maturation is not yet complete. The reorganization of cytoplasmic organelles has not taken place, and that extrapolates to the calcium ions. The movement of calcium ions across the membrane is not taking place properly, and this all therefore may hamper the fertilization potential, or it may affect the blastocyst formation rate as well. So the presence of high degree of granulation is not a good factor for fertilization rate as well as embryo quality. Apart from that, the presence of inclusions, again, that is little minor and major inclusions in the oocyte, they hamper the fertilization rate, embryo quality and implantation rate. And of course, the one thing that we all read, as Dr. Shubhashri has also said, that most of the times it is advised that if there are presence of SER, the smooth endoplasmic reticulum aggregates, which again is a manifestation of lack of cytoplasmic maturation. So in such cases, it is advised to leave the SER oocytes alone. There's one paper which recently suggested that you can do ICSI if you like, but then take care that you do not rupture or come across this SER while you are injecting. And personally, I believe that whatever you do, I mean, an SER oocyte does not form good quality blastocysts. So presence of SER is hampered oocyte maturation, lower fertilization rates, lower embryo quality, and when we talk of embryo quality, we are talking about the blastocyst formation rates as well. So the presence of SER definitely is not a good prognostic factor for blastocyst formation rates in women. Now, one factor that we all come across when we talk of patient characteristics, whether she is suffering from, so all the earlier factors that I have talked about, we see mostly in PCOS women. But when we talk of endometriosis in women with TB, we also come across an additional kind of abnormality, that is the viscosity of the oocyte is hampered. And high viscosity, that means there is a lot of elasticity, and sometimes you try to orient the oocyte for doing ICSI and it gets stuck to the needle, the injecting needle. And sometimes even after you have injected, while you are trying to come out again, it tends to just be pulled along with the injection needle. So the viscosity, and even if you have done, you have been able to do the ICSI properly, then the cone that is formed, it takes a long time to relax and come back to the normal position. So yes, high viscosity is associated with lower fertilization rates, lower embryo quality, lower blastocyst formation rates. And apart from that, it is so indicator of a rather viscous ooplasm is its adhesion to the spike of the injecting pipette. Sometimes conversely, you have a cytoplasm where you just inject and there is no cone formation, there is no viscosity, you just go in and come out. Again, that is not a good prognostic factor for fertilization and blastocyst formation, where there is absolutely, just as we say, the sperm sample is watery. So similarly in oocyte, and an oocyte where you just inject, you enter in and come out without any resistance from the ooplasm, there is no elasticity, there is no cone formation, so that is not a good prognostic factor for blastocyst formation. Presence of refractile bodies, again, so lower, associated with lower fertilization rate, lower blastocyst formation rate. Apart from that, the presence of dark oocytes. So overall, when we say that the embryo quality is hampered in the presence of dark, see, you see a normal control oocyte and a dark oocyte. Again, I personally feel we get such kind of oocytes in endometriosis, where there is a lot of ROS produced because of endometriosis. So yes, I don't know what the other faculty have experienced, but then mostly I believe that during in patients with endometriosis, we come across such dark oocytes, and that is not a good prognostic factor. Even if fertilization may occur, the embryo quality and the blastocyst formation is not good. Then there is something called as, presence of multiple cytoplasmic dysmorphism. So we'll come to that, where there are too many factors together that are occurring. So there could be the texture of the cytoplasm is not good, there may be inclusions, there may be vacuoles, there may be central granulation, then there may be also the presence of SER and refractile bodies. So when we come across such a situation where there are multiple morphological, structural and metabolic parameters that are hampered, so obviously, as you can see, this is not a good prognostic factor for blastocyst formation. See the kind of, it did try, but then the blastocyst formed is not good. So there are too many multifactorial morphological abnormalities that you see here, whether it is the ooplasm, whether it is the zona pellucida, it is the polar body, the cytoplasmic inclusions. So it did fertilize. You can see here how it has fertilized, but look at the quality of the embryo on day 3, where look at the zona, the perivateline space, the texture of the blastomeres as well, and how it is hampering the formation of blastocysts. So yes, the multifactorial, of course, that could be the worst nightmare for any embryologist, where there is a large perivateline space, fragmented polar body, cytoplasmic inclusions, dark cytoplasm, many vacuoles, fragments in the cytoplasm. So sometimes you see a cytoplasm which is not continuous, which is in bits and pieces. So all this hampers the blastocyst formation rate. So dysmorphologies in the meiotic spindle, the zona pellucida, the perivateline space, polar body, as well as presence of vacuoles or granulation in the ooplasm, all this lead to a poor quality of embryo and reduced blastocyst formation rate, if at all. And if at all the blastocyst is formed, then the outcomes, the pregnancy outcomes are not promising. So multifactorial parameters greatly hamper the blastocyst formation rate. Apart from that, this is beyond the purview of oocyte per se, but then after we have done ICSI, then not only the morphologies that we have just discussed, even the assessment of fertilization is a good prognostic factor of how the blastocyst formation will occur, or whether the clinical pregnancy rates are improved or not. So whether the placement of the pronuclei, whether there are two pronuclei or not, whether the pronuclei are centrally located or whether they are eccentric, whether the NBBs, that is nucleolar precursor bodies, are aligned or disturbed, non-aligned or scattered, and whether one is aligned, the other is scattered, and so on and so forth. So all these, a normal fertilization pattern seen at 16 to 18 hours post ICSI should view two pronuclei in the center with at least 5 NPBs, that is 3 and 2 at least in each, for a good prognosis for embryo development. If not, such kinds of fertilization patterns are not associated with great quality embryos and blastocyst formation. And lastly, one thing that if we really see the fertilization at the right time, the presence of the halo, so the presence of two polar bodies, the two pronuclei with adequate number of NPBs aligned and properly placed, and the presence of a cytoplasmic halo. This also signifies that the oocyte is now ready for the first cleavage, and symmetric cleavage is bound to occur in such cases. If there is no halo seen and the cytoplasm extends through and through to the ooplasm, then it may hamper the developmental potential of the embryo. So, I mean, these in a nutshell are all the factors that may affect the blastocyst formation rate, the oocyte factors, and I have tried to include the zygote pattern also, the fertilization pattern as well as the halo that could affect the blastocyst formation rate. So, in the end, I would just like to say that oocyte morphology is a very important factor. It is something very delicate. We have to handle the oocytes with care. Your lab conditions, you have to be particular about your oocytes as well. Oocytes tell you a lot. You just have to see properly, and there is a trend in some centers where they do not even check fertilization immediately after ICSI. Even not only day 3, they go directly to blastocyst day 5, and so I believe that fertilization and oocyte morphology is a very good factor in information about the embryo and
Thank you, Dr. Bindu. Such a nice presentation. We have definitely a few questions for you. The first question I would like to ask you is this fragile oocytes about which you were mentioning, when we feel no resistance while injection, how would you suggest to go about such kind of oocyte? Should we take some kind of precaution or some special technique for ICSI of such oocytes so that the less degeneration is there?
No, unfortunately, the thing is that the oocyte is already in that morphological state. You cannot do anything to rectify it, and since you have denuded, you cannot help but to do ICSI with it. But then this gives you an idea that such an oocyte does not have a good potential further, and it has a problem with C when there are too many oocytes as obtained. So there are bound to be a mixed bag of oocytes that you see, especially in case of PCOS, where there are some oocytes which come from smaller follicles. So in such cases where cytoplasmic, and I would just say, if at all, then when you see the oocyte under the microscope as soon as you have retrieved, then maybe you can segregate the oocytes where you see a cumulus COC complex which is too tight, and probably give it some more time before you denude for ICSI. So maybe, I mean, that could be one thing where you can isolate the oocytes with a good COC complex, and while doing, I don't know if that is the trend, while doing oocyte pickup also, there are times when the clinician says that this is from a smaller follicle. So such oocytes can be kept aside, and you can maybe keep them for a longer duration. Probably don't do ICSI at 38 to 40 hours. Maybe you can wait till 42 hours as well before you do ICSI of such oocytes.
Yeah, and there is one interesting question I saw in question box. This is regarding the zona-less, zona-free cytoplasm. Sometimes you get. So, what is your experience about it? Does it convert into an embryo, or
Yes, I have seen, but there is one case study, one or two case studies where zona-free embryo gave rise to a pregnancy. In my personal experience, I have just come across one or two such cases where the zona-free oocyte was, I mean, we did ICSI, it did fertilize, it did cleave, but then after by day 3, the blastomeres segregated. And interestingly, though since each blastomere could be totipotent, so one of the blastomeres did try to form a blastocyst. I mean, that was very interesting. We did not transfer, of course, and it did not form a full blastocyst, but then it did try to have some cavitation in it. But then apart from that, I have no experience. I have not transferred any such zona-free embryo. I have seen the formation of 6 to 8 cells embryo without the zona, but then they scattered later on. The blastomeres.
okay, okay? And we'd just like to have last question. Is there any correlation of mitochondrial DNA with oocyte maturation, oocyte quality, embryo formation?
Oh yes, because it is when we talk of the entire energy of the oocyte comes from the mitochondria, and I mean there is this calcium pumps also which are channelized. It is endoplasmic reticulum and the mitochondria which are responsible. So the release of calcium ions in discrete quantities is all regulated by mitochondria and endoplasmic reticulum. So yes, mitochondrial defects will definitely hamper the potential of the oocyte maturation itself. Forget the blastocyst formation. The maturation.
Okay, okay. Okay, so thank you, Dr. Bindu. Such nice presentation. Always a pleasure to listen you. Over to you, Yoshida, for next proceedings.
Thank you, sir. I think there is no questions left. Thank you, sir. Thank you, ma'am. Now I welcome Dr. Nancy for further session.
Thank you, Yoshita. So after this wonderful presentation by Madam, let us move towards the next session of the evening. That is the panel discussion on the most highlighted topic of the year, on which we all are getting regularly updated on, and we all are talking about it on every possible group. That is ART Act. So today we'll try to cover a part of it, that is fertility preservation according to new ART Act. For moderating the session, we are having Dr. Rahul Sen. Dr. Rahul is currently working as consulting embryologist in Neelkant Fertility, Jaipur. He is an executive member of ACE and nominated as mentor in ASHRAE mentorship program 2022 and 23. Is also a treasurer in ISAR Rajasthan chapter. Is invited faculty for MIT University, and he is in the field from last 13 years. He's published many national and international papers on many journals. He is also a reviewer of journals for reproductive health care and medicine. He's member of ISAR, IFS, and ASHRAE. And next we're having Dr. Atita Shinde. She is ASRM certified embryologist. She's working as a chief embryologist at DRLH Hiranandani Hospital, Mumbai, and she is consultant embryologist for more than 20 years. And she is also a trainer for SR embryology course from 2018 to 2022. And she has done her embryology blastocyst course training from Istanbul, Turkey, in 2018, and she's also certified as QA/QC certification course and completed it from Denmark in 2019. She's also managing partner of ART Solution LLP. So I'm welcoming you both for introducing our panelist of the session.
Yeah,
Thank you.
Thank you, Nancy, for this wonderful introduction. Please let me share my screen. can you please stop sharing?
Mr. Suman, Mr. Suman, can you stop sharing your screen? Thank you.
So much. Is it visible?
Yes, sir.
A wonderful introduction, and for the next panel, as you have already mentioned, that is on fertility preservation as per the new ART Act. And for the panelist, I would like to invite Dr. Shrikant is not here. Charulata.
Sir, your voice is so low, sir. It's not audible.
Is it audible? Is
No,
it
not
audible now?
Not clear.
the volume is.
Now is it clear?
It is clear, but the volume is. I think volume is low.
Let me check. Now is it clear? Is it
Yes,
Little
go ahead,
better, sir.
Rahul. Yes, go ahead, Rahul.
Okay.
So, I would like to introduce my panelist, Dr. Charulata Chatterjee. Ma'am is a senior embryologist and consultant at Fertility Clinic. Ma'am has a vast experience of more
Sorry,
than
sir. It's not clear at all, sir. Voice.
Not audible, sir.
Not audible, sir.
Now is it clear?
Yes, sir. Perfect.
Okay. So I think headphone is working. Okay, so I would like to invite my panelist, Dr. Charulata Chatterjee. Ma'am is a senior consultant embryologist and having vast experience of more than 26 years with accomplishments of inviting faculty as speakers in various workshops, CMEs and conferences. Dr. Pranay Ghosh, Director, Elixir Fertility Consultant at Double Helix Clinical Cytogenetics and Reproductive Immunology Center. A very dear friend, Dr. Nisha Chimote, clinical embryologist and having vast experience of practicing embryology more than 2 decades, and is being in the members of various national and committee in the societies. Dr. Gaurav Kant, he is again a senior embryologist at Akanksha IVF Center, co-convener SIG Embryology IFS, and co-convener SIG Embryology at IFS. Ram Prakash, he is a embryologist and laboratory director at Omea Fertility Group, New Delhi, Max Hospital, co-founder Angel Fertility at Nepal, certified clinical embryologist performing more than 8,500 cycles. So, not wasting any more time, we are going towards the panel, and I would like to invite my co-moderator, Dr. Adita Shinde. Adita, you can take away the panel of the first question. Yeah, Adita. Hello. Adita is there.
Rahul, you go ahead with the first question.
Yeah. Okay then. So I'll ask
Audible?
my. Yeah, Adita, you're audible.
Yeah. Hi everyone. Good evening. So we will. Everyone knows our subject. So subject is the fertility preservation as per the new ART Act. So we will start. Hello. So we will start with the fertility preservation definition. So Gaurav Khan, can you please tell me about the definition? Define the fertility preservation.
Thank you so much, Atita and Rahul, for having me on board on a panel. So, for fertility preservation, as the term itself says, that preserving the fertility means that could be anyhow, whether you're having a cancer or you want to delay your fertility because of socio-economic situations, you want to delay it because you want to work more. whatever situation is, and our help, we being there as an embryologist or a scientist, how we help them in preserving their fertility for the future use.
Okay. So definitely fertility preservation is defined as a use of the available technologies to help individual to retain their fertility or ability to procreate. Fine. So we will go next. Anyone want to talk regarding this? Ma'am? Charulata ma'am?
Yeah. What do you? So preservation, fertility preservation means either you freeze your gamete for a younger woman, for any for the career of point of view, or delaying the motherhood for some other reason, social reason, or that, so they can freeze that oocyte, or sometimes even couple wants to have that freezing their embryo, and later they can go for the baby or whatever. So that's what it's called, fertility preservation. And as long as cryopreservation technique is concerned, it is now vitrification has taken over completely with the slow freezing, what I used to do years together, sitting before the K planner.
Okay. So how will you provide the services to patient? What all the services we are providing to patient regarding the cryopreservation?
So like, as if it is a fertility preservation for individual going for oncology treatment, or either it are major or minor. If maybe you will question later what is the difference between minor and the major, and how do we take the consents and all that. But definitely before going go ahead with the chemotherapy or what kind of their cancer therapy, we would like to freeze either sperm or the oocyte. And the protocol is very well established now. It's not more a research technology. It gives a very good retrieval, very good revival, and very good chance of success for the individual going for the preservation.
Yeah, but for that we require a counseling.
Absolutely.
Yeah. So what is the cryopreservation, Nishat?
Yeah, so cryopreservation, as already discussed, is basically you're trying to freeze any gamete, especially oocyte, sperm, or maybe an embryo. Generally, embryo is the most. So we are freezing these, especially in liquid nitrogen under minus 196 degrees. And that is what we exactly do. And slow freezing, as earlier mentioned by Charu ma'am, that it used to be in vogue, and now we have completely shifted to vitrification, and that is what we do. Only slow freezing works mainly with the tissue freezing, that is the ovarian tissue and the testicular tissue. And we have not reached the stage where vitrification can take over in these situations. So that is what basically is happening right now.
Okay. So definitely cryopreservation is divided with the slow freezing and vitrification both. Okay. So now we are doing vitrification lot. I don't know how many people they are doing now slow freezing. How many are?
We stopped slow freezing in 2008, 7 or 8. I think we stopped slow freezing.
It's a long way back.
Yeah, and you have to sit for 6 hours to just freeze 2-3 embryos, and your survival rate was not more than 60-70%. So,
and as long as Nishan said that for ovarian tissue and the testicular tissue, that is also, I think, few groups in India are doing that for the slow freezing. But with that, how many successful retrieval and again like successful live birth has done, that is again it is the study phase, at least in
India. And we have to also think about the cost effectiveness of the procedures and the time given. So yeah, it is not that much efficient, we can say.
Absolutely.
Yeah.
So
any particular techniques whichever we are following for vitrification?
I think
any particular method?
I think I want to answer that.
Hello.
Can you hear me? Can you hear me, Atita?
Yeah. Yes, Gaurav.
Yeah, Ram Prakash. Yes.
Ram, you want to answer?
Ram,
please, Gaurav.
any particular method are you following for vitrification?
I think Gaurav wanted to say first. So after you.
Gaurav, yeah,
Go ahead,
please.
Ram. Go
Gaurav.
ahead. Same. We two are carrying the same soul. Don't worry.
We all are in same suit actually. Yeah, please go ahead.
So basically, I think slow freezing, there's no question now. I think why are we even discussing slow freezing now when it's like it's absolute technique now?
Outdated.
We all have moved to vitrification. I think we all are getting absolutely very good results on vitrification, and which saves our time, gives us more utilizable embryos, survival rates, and I think it's superior to slow freezing that we all know. But when it comes to techniques, of course, like I'm a believer of open carriers. I usually mostly use open carriers in all the cases, and I have very limited experience with closed carriers. So I am not sure I'll not be able to say more on closed carrier things. But yes, vitrification with open carrier is amazing technology, and I think most of 80 to 90% percent of embryologists are using these kind of technologies. What about you, Gaurav?
Okay.
You?
Gaurav, any other
We
points?
have covered everything. I think I'm covering in the same shoes, right? I'm also a big in favor of the open system because I don't find any logic of using the closed ones where you don't have that much of cooling and warming rate. You bring vitrification with the concept of a single thing, that there is a high cooling rate, there is a high warming rate, and you are just going opposite to it by going into the closed system where you're reducing the cooling and the warming rates. And looking at the infection part of it, what I'll say is whenever you put anything in the liquid nitrogen, it just encapsulate there only. They don't travel into liquid nitrogen like we travel in the buses on the car. They just stuck on the leaves there only. And what we have nowadays in our labs, we have a different infected containers where we put all the infected ones in a separate ones. So I don't find any till now use of the closed ones that often in India of every side.
And
Using
thousands
closed
of
system in our
vitrification has been done successfully with the open system. I don't know how many. I have never came across any, infection or in the frozen embryo. So it is perfectly going well.
Okay.
Using
So,
open or closed?
Nishan, do you have any?
Yeah, complete. Totally. I'm with open. I mean, closed is again not cost effective. And the rest already mentioned that the heating, warming rates and the cooling rates, they make a lot of difference. Obviously, with the open system, we have more, no doubt. So it works better. Pretty much the equipment required for closed system is slightly expensive. Open system, you can perform in any center, especially you're a freelancer. You can just take in your kit and just thermocol box and you're done. That's it. I mean, there is no equipment required.
Okay. So we all are favor of vitrification and open system, not a closed system. But yeah, so somewhere some papers are saying that for HIV and some kind of STD test and all, we have to go ahead with the closed system. So anyone?
There has been never
it?
any documentation of cross-contamination with the embryos and oocytes. Just one paper once many years ago, that's it. And that can be a fluke because there have been, as mentioned, thousands of vitrifications happening. And there has never been any case. Forget any viral contamination, just bacterial contamination for that matter does not survive any kind. So what is the point of doing that?
Okay, so all are favor of closed system.
Yeah.
No, open system, sorry. Okay, so the next question is crucial
Okay.
steps in the process
Yeah.
of freezing. So what
I
are
think
the
we
crucial
can
steps?
ask Pranay. Pranay is there.
Pranay is there?
Can you means just briefly means summarize how we can maximize this process of vitrification, as it has already been discussed a lot that vitrification is now the major step for the process of cryopreservation. So what do you think that these particular points or the steps can be the maximizing points? So Pranay is there.
Thank you for having me here. And I wasn't wanting to jump in because I had nothing more to add. But you have asked me a question which in itself is a half an hour long presentation. So
yeah, actually,
so
but
I just want to say that you can have the KPIs and everything, but I always say you are just as good as your last warming, because we have 95% trial survivors, but those 2 to 5% where we don't have the adequate trial survival, that shakes you up, and then you do a lot of troubleshooting. So first and foremost, you have to stick to the manufacturer's guidelines. I mean, you have to stick to the T. If the manufacturer mentions that you have to use 300 microliters of TS, VS, and 4 ml of TS, as a beginner, you cannot compromise on this, because this is when you're starting, and this is where you will probably not have adequate car survival, even if you adhere to the recommendations. So there is no.
Pranay, can I butt in? I need yeah. So you're mentioning about the microliters. So there are people who actually make 20 microliters drop or smaller drops. So do you think that it really makes a difference that your survival rate is as equally good with the 300 microliters, or why do people do that? I need to know that.
Why do people do that is a philosophical question.
That's all due to.
I've seen people doing warmings in 200 microliters, and that's beyond me. That's just beyond me. So, you know, a thawing kit of kitazoto, for example, is good enough for 2 patients. If you're wanting to use it for 20 patients, and you're charging patients adequately,
it's
saving much. So people will try to tell you that with the practice and trial and this and that, they are having adequate cryo survival. And but one fine day when you don't have a single blastocyst that you have frozen for a patient who had done cooling, and this did not warm and gave you the adequate cryo survival, you cannot go back and question what went wrong. Was it the media? Was it the batch? It was you. And the moment you compromise on things that are not supposed to be compromised with, so again, 90% of the days, everything will be hunky dory. But once you're stuck in a rut, there's no troubleshooting for those 5 to 10% of the cases. So, my first step is to optimize crowd survival, to stick to the manufacturer guidelines, to stick to the recommended volumes, stick to the recommended temperatures and timings. Second most important tip is to have a decent, a proper embryo selection, whether it is day 3, day 4, day 5, day 6, day 7, so that you only vitrify grade A and grade B embryos. Vitrify what you would end up warming and expect 100% crowd survival and end up transferring. So that is the second point. You cannot freeze grade C embryos and expect a grade B or a grade A on cryo warming.
Yes.
Try to minimize the number of embryos that you freeze on a device. So, especially now we are since moving towards ESET, it makes sense to freeze at least the blast singly, and even the cleavage stage embryos not more than 2 on a device.
So you are recommending to freeze a single embryo or a single blast on a single device.
I'm recommending single embryo transfers for the patients who actually are candidates for single embryo transfer. So there is no point doing a DET warming 2 blast. You get 2 forays and you end up refreezing 1. So it's exercise in futility. So
And the next the major I think question here can be is what according to you will be the technical proficiency of an embryologist. Means if a trainee embryologist is basically doing around 50 number of vitrification cycles, so now is he more efficient to perform the vitrification properly, or means how many number of the cycles according to you an embryologist should perform to have a good vitrification this process?
So I'll just make a slight comment. I always hold my breath for 3 procedures: every single oocyte that I inject, every single warming that I do, and every single biopsy. So there is no getting over that, because these are things where I feel that it is more of an art rather than science, because you might load 2 blastocysts on the same carrier device, and they have been exposed to precisely the same things, and on warming, just one of them makes it. So it's more of an art rather than science. But your question, I think that it's good to start under a mentor, because starting under a mentor will cut down a lot of headbanging and troubleshooting that you would otherwise learn from your own experience. So using specifically designed vitri plates that have sloping edges. I mean, I think it's when I started, we were starting with the drops, and then if you leave these drops for more than an hour, you notice some kind of evaporation on the lids. Not recommended. Again, So my point is start under somebody's mentorship because they'll tell you points that use, if you're starting as a novice, don't use 170 microns, use a larger bore or even for previous stage embryos. So these will drastically cut down your learning slope. But I think vitrification is a skill much easier to learn. 50 is a good number. Yeah, you can easily, if you are following everything to the T according to the manufacturer, that should do it.
Any other panelist need to comment? Yeah, yeah. Yes, Gaurav. Yes, Gaurav.
Rahul, I want to add vitrification. Sorry, Ghosh, vitrification is the most difficult process to do in the lab because there is a timing involved, right? You can, when you are doing ICSI, you have time with you. You can stop it anyway. But once you are doing vitrification, you cannot stop it. You cannot just pause it and go somewhere. You have to follow whatever the guidelines are.
Yeah, I'm not talking about traveling embryologists at all. You need to be inside the lab. Your mobile should not be there.
I think,
and you should be doing only one vitrification at a time. There's no
I
point.
think
I
I think not only the time, but yeah, embryo is exposed to adverse conditions like the osmolarity and all. Means the cryoprotectants.
My point of saying
The
this,
major.
Rahul,
Yeah.
is
Yeah,
when you have the delegates here listening to you, the message should be that don't take vitrification that lightly. It is actually a step where you need to be very careful at every step. Whether you're putting in the ES, whether you're putting in the VS, or you're loading on the devices, you have to be very particular with every step. As Dr. Ghosh said, so you need mentorship, you need training under someone to perform these steps. I don't want people to just go tomorrow and start loading the embryos and definitely that vitrification. No. It is like magic. You cannot control it. Once you do that, it's like a magic. You do vitrification, you do warming. It looks like a magic. You cannot stop it in between anywhere.
So any other can comment on the proficiency level or proficiency of an embryologist with the process of vitrification? Charu ma'am, can you?
Yeah, so Rahul, what happened, like, both of my colleagues, Gaurav and Pranav, are correct in on their way. But once you, first is once you concentrate on the procedure and the step, you can do at a time even 4 or 5 patients loading, keeping a 2 minutes or 1.5 minutes interval. You know that how much time you are doing in the VS, how much loading. So that is once it will come with the experience only. And now with all this improved media and all that, like junior embryologists should start doing, but they should not be even overconfident that can be done, like, it is just loading on the device and dipping into the liquid nitrogen. No, it's not that. But yeah, it is also not that people think, no, we have to take out a small little drop from the VS and there should not be, it should be dried up. And no, it's not like that. You should know that what procedure and what media and what are the ingredients in VS and how it adversely affect and what is the minimum volume or what is the maximum volume which can be kept. So it all comes after experience. But yes, initially they should learn from the expert only.
So how many oocytes or how many embryos on one device, ma'am?
I load 4 oocytes per one device. And if it is a day 3 embryo, nowadays it is not. We are almost all the clinics are day 5, but day 3, I load 3 embryos, not more than that, because we will not end if it is excellent. And it depends upon the number of embryos formed for that patient and the age and all that. So we should keep in that mind that how many, if patient is young, we have 2 good quality embryos, then we'll just of day 3, 2 only will load. If it is young patients and blastocysts, we'll definitely go with the single blastocyst. If patient is more, if it's pooling, then not more than 2 blastocysts per device. Never.
Okay.
Can I make it simple? So it basically depends upon the protocol of embryo transfer with the clinician. If you have protocol of transferring 1 embryo, you will definitely freeze 1. If you have protocol of transferring 2 embryos at day 3, you will freeze 2. So basically, it depends upon the transfer protocol by the clinician and the center.
Can we have the next question, Aditya? Yeah.
I would just want to add one last thing where you want to say wanted me to summarize the how to optimize. So all of this is futile unless you're having, this is just for the sake of completion and for the beginners. You need to have very robust labeling so that all of this, ES, VS and all, it does not go in vain, so that once you are going into the cryo can, or somebody at the clinic who's different from the person who has done the vitrification is going for thaw, he is able to find the device, because at some of those centers we have seen that this is quite a cumbersome thing, wherein the identity, either it is not labeled adequately, or there's just one identifier, or it is a marker that is rubbing off. So have a robust means of identification so that you are able to warm what is desired.
Okay, so we'll move next. Uh, why sperm preservation and for whom? Um, who's so Ram Prakash? Can you please answer?
Sperm preservation is a very large subject. So it can be done for the normal patient also, like patient who walks for a normal IVF cycles. We can preserve their sperms for backup if we know the history. If there is something like patient who is not able to give sample on the day of ovum pickup, we can preserve their sperms. If patient is traveling out of station, or if traveling to some other place, and they have already started the procedure, we can preserve their sperms. Or if there is something which on the day of pickup the patient cannot come, we can preserve their sample. And especially in of course when we talk about fertility preservation, so sperm freezing is one of the these days I think in all the clinics we can see the patients or the young children's or adolescent children's, they are coming to the clinics for the sperm freezing and all. Being like I work with Max Hospital, where we have cancer unit, so there is a lot of, I mean, every day there is at least one or two queries about oocyte or about the sperm. So there I think it is a well proven that sperm freezing can save us from many things.
Okay, and PISA and PISA as well.
Yes, of course, of course.
And what method you are preferring, like raw freezing or process freezing for the normal infertility patient?
Again, it depends, like for how long we want to preserve. For the backups, we of course we go for raw freezing. We don't process them. And if you want to store it for, like, especially for fertility preservations, or if in cases where patient has to go for any surgery or something, in those cases, if you have very less sperms, or if the count is oligo or something, in those cases, of course, we process them, and we try to accumulate more sperms in a while. And we ask them for multiple collections, and multiple times they can visit the clinic and they can give their samples.
Okay.
So again, it depends on the sample.
Any experience on sperm breeding?
Yes, we do a lot. I mean, not recently, I mean, like we keep on doing in cases where micro T-cells are there, in T-size sperms, we have done ICSI, and if there are remaining sperms, we do sperm VD.
Pranay, do you have any experience on sperm breeding?
Yeah,
And what is the result?
I mean, we were wanting to freeze, so we have done about 8 or 10 warmings, thawings, if you may, and it is just by choice. It is not necessarily for micro TC samples. We are doing it for TC samples, wherein otherwise as well with slow freezing we would have found. But this is just to acclimatize ourselves with the art of freezing sperms on sperm VD, so that when the need arises, we are able to do it more confidently. So up until now, we are happy with. It's just a little messy. I don't like working with
time consuming as well.
Yeah. So otherwise, you have a good cryo survival, but it is just that the cost of using the sperm VD for every TC, at least TESA TC case, does not necessitate.
We can have highlights from Nishad.
Yes.
Are you aware, means using any techniques to preserve limited number of spermatozoa? What's your take on this?
Sperm VD has been the most efficient method till date. Obviously, as mentioned earlier, yes, it is not cost effective and it is time consuming. But it is way better that we can go in for such a method, because every time taking doing a biopsy, and once you've done that, testis is gone. So it's better that you take out as many sperms as possible and store it for multiple uses. So this device actually helps you in having multiple doses, or you can freeze on different devices accordingly, and have multiple cycles of ICSIs if required, if there is a failure in the first case. So yes, sperm VD is helpful. I've done a few cases. The retrieval is good, and the thawing rate, the survival rate is pretty much, I would say, around 90% above. So yes, it is efficient.
Did anyone try with the 0.5 molar sucrose and the goblet directly into the liquid nitrogen and keeping that goblet into the cryo vials?
Yeah, I've
That is
done that,
also
but it's very trial and error. It has to be
no.
very
That
perfect.
also gives fantastic result.
I think there is one more paper recently that with dextran and with sucrose, the survival rate has increased. I think, yeah. So
Generally,
dextran
they
is a
do
very good
direct
one. Yeah.
also, but 0.5 molar sucrose will, survival will, afterthought it gives good.
Yeah.
So even in they do freezing into the denuding pipettes also.
Yeah.
I think initially it is time consuming, but at the time of thaw in ICSI, it saves you a lot of time, and you don't have to again take out the whole sample and hunt for sperms. So there are drops, and you have marked them that there is a sperm. You just go there and pick it up and inject them. So it is.
TESA is very risky. You never know you'll find the sperms while you're doing the procedure. So if you do it earlier, retrieve the sperm while doing the oocyte pickup, you know that whether you're going to freeze the oocyte or actually you're going to do the ICSI. So this is a guaranteed method. So in such cases where, please go ahead.
Yeah, please continue.
Yeah, so in such cases where there is no guarantee, and that is one of the you have nightmares the next day. You got pickup and you are waiting for TESA and you don't have sperms. Then what do you do? So such devices already preemptively taking out the sperm, freezing them, and then planning your pickups definitely helps you. That we've got live sperms, motile sperm, vital sperms, and you can just thaw them and do the ICSI as regularly. That is way better.
What is about the PISA sample freezing? Are you getting any outcome out of it, Nisha?
With PISA sample, PISA, I mean, we don't with the sperm video say.
Yeah, PISA sample.
Percutaneous. PISA, yes, definitely, but PISA we have not done with sperm video mostly. It's testicular sperm mostly.
PISA is generally for if it is obstructive as well. Otherwise, whatsoever TISA is done either for the high DN and all that. So PISA won't work. Generally, it is TISA only.
Yeah, PISA is okay because you're going to get sperms.
Yeah.
And in that case, if they're immotile, you can obviously add theophylline, or you can obviously go in for
in case of
test
PISA,
and then save the sperm. Yeah.
The routine rapid freezing also works. So
yes, theophylline is actually God for us now.
It's a savior.
Yeah.
Yes, ma'am. So, ma'am, there is one more question for you. For whom we can do oocyte freezing, and what about the safety issues and this?
For whom we cannot do that, you ask. Everybody,
for
everyone we can do. So oocyte freezing basically is a method of like it is initially when that was so much we were worried that we are freezing and gamete and whether we'll be able to. Even I had a sleepless nights when I first froze the oocyte but now it is a part and parcel of the routine procedure.
Yes.
Sometimes in the busy clinic, even though patients just turn up, they don't have backup sample, and that kind of cases also we are has to freeze the oocyte. That is one very rare reason, but it is there. So that is one of the reason when by choice patients wants to delay, single lady who wants to do. So oocyte freezing, as it says that anything related to assisted reproductive technology, it's an art only. So what we need is our any painter needs their all magic tools. So we also need our magic tools like vitrifications device, vitrification procedure, vitrification solution, how to go ahead. And as long as oocyte freezing is concerned, every embryologist, experienced and skilled embryologist has their own method to do. Either they will go with the basal solution, just give some little time and then go to the ES and all that. All other devices are also available, which I do not use a special Petri plates and all that. But with experience, I use only plain, dish, keep a droplet of like not 20 microliter where you will not have, you have to use the, manufacturer advice, and it's kind of routine. So I don't think there should be any issue with the oocyte freezing. But as long as, yeah, theoretical part is concerned, whatever your slide says, that can be possible, the damage can be possible, oocyte can be degenerated, all that is there.
Okay.
For oocyte cryopreservation, the most,
Yeah.
can I add on?
Yes,
Please,
Gaurav,
please,
please
You
go ahead.
need, you
I'm
need
supposed to ask
in
you
less
only,
than
no?
in less than 35 years of women, you need at least 15 oocyte for one single birth, right? And for the age of 35 to 40, 35 to 40, you need around 16 to 25 oocyte. And in women more than 41 years, you need 40 oocytes to achieve one live birth, right? So for oocyte freezing and all, whosoever is deciding, it should be done early in young ages. That's why what we are discussing here is fertility preservation. If one is planning, it should be done earlier. In
Gaurav, they should have 40 oocytes by the age of 40.
keep doing the pickups, right? Keep doing the pickups. So the point is the quality of the oocyte. It is better if you try to retrieve it from the younger women. And if you want to think about the fertility preservation, try it earlier. Don't delay it too much.
Okay. Anyone has done ovarian tissue preservation? Pranav?
Just done it on, just done it on the sheep model where it was actually a thesis. So, but I really don't recommend it to any, because Dr. Charu did mention that you have to be realistic while discussing the expectations out of it. I mean, you can even under institutional or other experimental settings keep on doing it, but do you have realistically, at least for our country, any live births out of it? So I really don't see a point, especially now, wherein we are having to refuse even young adolescent males and young females who are between the ages of 16 to 21, who otherwise could have been offered onco-fertility cryopreservation, but now they have to approach the board, and on a per case basis they'll have to be taken up. So I really don't know if you should be discussing the OTC, but yeah, I've done it, and it's a task. Somebody added, yeah, it's a task.
Yeah, as
It
per
is
Ram.
difficult.
I have not done it, and sorry to say, I don't have any experience on this.
And ma'am, do you have any experience?
Not actually on the human things. I have done few where it is, done for that, and even I have tried some vitrification also, but that it is only on the experiment that I can able to do this. That's the only satisfaction, because that's not on the real case, no.
Yes.
See, the cost, the time, everything is so much. Plus, here you're thinking about 0.5% pregnancy rate chance in so many years. And first of all, you have to also think the graft should be accepted. You know what will happen in that cases. So there are so many multiple factors that actually don't allow us. So commercial viability of oocyte tissue, ovarian tissue freezing is practically not there. It's not viable. So maybe in another 10 years, we'll be in a different scenario and we'll be talking on a different task
Maybe
regarding
that
ovarian
time
tissue.
we'll have one webinar like this, that ovarian cryopreservation. Oocyte freezing will be outdated.
Can I say something here?
Yes,
Yes,
please.
sure.
Yes, sir.
See, recently I have not recently, means it is an year back. We did some ovarian tissue freezing in Bhubaneswar at Dr. Sujata Kar's place, and just 15 days back, 10 days back, it has been transplanted back with the successful survival. So, keeping finger crossed, maybe we can come up with the first in Bhubaneswar with the frozen thaw ovarian tissue pregnancy. So it works actually. You have to do trial and error definitely, but ultimately it is an proven thing. Like you can freeze ovarian tissue.
Yes. So after the sperm and the egg, now jumping on to the embryo part. So my question directly to the panelists will be: what is the preferred day for the embryo freezing? Means a cleavage stage, early cleavage, or a cleavage day 3, a blast embryo. Yeah,
Day 4
Nisha, go ahead.
embryos.
Yes.
That actually, can I add, Rahul?
Yes, yes, yes.
So you can cryopreserve, or basically what you do is vitrification or cooling at any stage. So that depends upon the number of embryos you have. If you have 2 embryos or 2 sites, you fertilize them, you have 2 embryos on day 2, you don't want to go to the blastocyst at that time. And if the patient is willing for a transfer, you can freeze at day 2 or day 3. When you have multiple embryos, you can try to go for day 5. So basically, you can start freezing from anywhere. Day 2, day 3, day 4, day 5. The results are same, equivalent. But all depends upon the number of embryos you have in your hand.
Quality and the quantity, both.
Also depends on the proficiency
And
of
all,
the performer.
Yeah,
I would
yeah,
disagree with
yes.
that, Gaurav. I will slightly disagree.
Please,
See, the
Rahul.
quantity, yeah, the age is a factor, yes. The thing is that even if I got two oocytes, I will go for blast blindly, because at least one can become. That also depends on the lab efficiency and the stimulation protocols, the what has been pre-examined earlier. These factors are very important. If the oocyte quality is good, if you're checking every grading every time, so in those scenarios also, and if you've got a
Nishad,
policy
you want
of
to say that you are doing 100% blast transfer at your center.
yeah,
What is your
100% blast
cycle
transfer.
cancellation rate in your center?
2%.
So what we do, Nishad, rather what we do, we ask the
We'll
patient.
send our patients to you, I guess.
We ask the patient.
No. There are several papers where it's already mentioned. If you see it, the blastocyst cancellation, the day 5 cancellation rate in many papers with where they have done more than 14,000 transfers, it's only 2%. And if you see day 3, it is 3%. यानी 100 में 2 patient and 100 में 3 patient. So why not go for blastocyst?
Nishad, the problem here is in India, the cycles are sponsored by the patient themselves. It is very difficult to convince them that whatever money they have paid to the center, it's nothing now. They have nothing in their hand. So it is basically you have to ask the patient, say this is a scenario, what you want.
See,
But
there
you
are
want
a handful of
day 3
patients.
or day
I
5.
will definitely say there are a handful of patients where I have to go for day 3, maybe like maybe 3-4 in a year. That's it, not
Go for
more than
blast.
that. Yeah. If it's endometriosis, it's a day 3 transfer, grade 3 and above.
Why are you biased with endometriosis only then?
Because it doesn't form a blast. So are you going to tell the patient that? Or you can do that and tell the patient it's not a blast. That's the counseling is important.
No, Nishad, if you check your statistics with the usable blastocyst rate for severe OAT or a TISA, that will be very, very less. In such patients also, looking to the woman's age, I go for day 3. If it is woman is young and oocytes numbers are more, then only I prefer. But otherwise, in case of you check, if you are following Vienna consensus, if you see the usable blastocyst rate, it will be definitely less for the severe OAT and TISA or all that.
It's very true. It's very true. But the only thing you utilize the blastocyst rate, utilization blastocyst rate also depends on the trophectoderm mainly. If you are, it's a A grade or a B grade ICM, there is no problem at all. But if it is a C grade trophectoderm, it will not get implanted. And if it gets implanted, there will be a first trimester abortion. So you have to think about that also.
As it is correct. And as it is so far, like, patient is only paying from their pocket and coming. So it's better always we take the informed consent. This is your chance. This is the blastocyst formation rate for such case. And let them also, take it into the confidence.
Ma'am, here is where the counseling matters a lot.
Absolutely.
So if you do the counseling properly, the patient will not get disgruntled. You already told the patient that there's a chance that there won't be any embryo available or blastocyst. So mentally and mainly on the consent, you have to write it down. These are the 2 things. If you do it, the patient will not say anything. They understand because you have given them a real life scenario. If you give a very rosy picture, then obviously you're going to get the backlash. So there is the difference.
And are you collapse the blastocyst before freezing?
No,
anyone?
I don't do.
That depends upon the type of media you use actually.
No, I don't do.
Whether you're using
And
a
blastocyst freezing is the easiest thing. Like, it is the way you freeze, the way you thaw. Though it is as simple as that. There is nothing, touch wood, nothing to going to do blastocyst if you follow the protocol perfectly. So I do not collapse the cavity. I do not collapse the cavity, neither with the laser, not with the mechanical. No, I freeze expanded blastocyst.
Ma'am, I'll agree with what Gaurav said, that it's more of an art.
Yeah.
Freezing and thawing. So you have become an artist. For people who are not well versed, will not say that what you are saying. So there lies the difference.
I always say that, we are artists because we are the only one who has three things coordinated at a time: hand, heart, mind, eye. Four.
Four. Also, Gaurav, you are telling something about the media and
Yes, thank you, Adita, for considering it here. So basically, what we have in media, there are two compositions of media. One is having generally the DMSO and propandiol, and the other one having the propandiol and ethylene glycol. So when you're using propandiol and ethylene glycol, you have to actually use the laser and take out the water from it. The reason being is, in blastocysts, you have the aquaporins for the DMSO. Right, so DMSO goes and take out the water, but not for the ethylene glycol. So it takes longer time to take out all the water. So read it in your media, what is there, whether it has the DMSO with propandiol, then you can freeze it without the use of laser shot. If you have propandiol and ethylene glycol, then give a shot and then freeze.
Okay. And what about the blastocyst biopsy after doing? How long you're waiting for vitrification?
Immediately. Why to wait? Our target is done now. We want water out. It is already.
In one way, you are saying you collapse the cavity, and one way you do biopsy, it is collapsing only. So I don't wait after biopsy. I freeze it
Immediately. You freeze it.
Yeah.
Okay. Rahul, the next question.
I think we can jump over to the the legal part of this meeting. So we are now all aware of the fact that the ART Act and the Surrogacy Act has been penalized, and as per the instructions from the central government of India, there has been a lot being said about the cryopreservation in the law. So I would like first Charulata ma'am to please highlight how one can proceed by considering with the cryopreservation. So what points one should take care in the lab?
See, now as long as first, let me just come through the consent part of it. This is, sometimes I feel that whatever act and bill and everything, it is for good. It is to be, streamline the things. Now we have consent for oocyte freezing, for major, minor. We have consent for embryo freezing. We have the things that what has to be done. In that, one point has been, eliminated, that you cannot donate that embryo to anyone. Either you perish or you give for the research purpose, or let our partner decide. So that's what is the new act says. So, and what was the next question, Rahul?
Yeah, not only the consent part, I think it's starting from the registration. While registering the center, there has been a lot of questions regarding the freezing, whether we are freezing the sperms or oocytes, embryos, testicular tissues. What is the technique? So means now the in the act it has been very specifically mentioned that what type of gametes or embryos are being vitrified by which of the following procedure, and whether we are doing it or not, we have to mention it. And they have
Absolutely.
also mentioned a set of clinical requirements that a bank and the clinic should have when they are freezing, when they are having a freezing facility in the clinic or the bank. So I think Nishad can go ahead with what can be the basic requirements, what has been mentioned in the bank.
For the ART bank or the ART clinic?
I think it can be the same set.
I think there's a lot of disturbance. Somebody's mic is on. Can't speak.
Yoshita, can you please mute yourself? Yeah. Yes, Nishad.
Yeah. Right. So obviously, bank and clinics, according to the new 2022 one, they have reduced on what 2021 was. But 21 was much better when it comes to the detailed information. So here with the ART clinics, let us begin with that. Obviously, they have not mentioned what is actually required. They've just mentioned a laminar hood, a microscope, and just basic things. That is cryopreservation equipments. I am not sure what equipments. One is our straw, your liquid nitrogen, your container, and forceps. That was the fourth thing if you're doing vitrification. In case of sperm, obviously you can use sperm BD devices, or you can just go in, as Charu ma'am said, that you can just flash freeze it for vitrification. And slow freezing, obviously the media is required. That is the main thing. So other than that, nothing much. Yes, I would like to add to it, you need good quality divers. Mostly we use the basic BP ones. You can go in for the medium range and the fancy ones, depending on your requirement and how many you're freezing. And especially the most important thing that they have not mentioned, and that I feel that it should be a part of every IVF center, is your monitoring systems. If the liquid nitrogen level drops, because we know what happened in Cleveland, what happened in other parts of the world. So it's very important that you have a very good monitoring system with your phones and apps available, that you are able to track anything is wrong. And you can actually, if anything goes wrong, you've got actually evidence-based retrospective analysis present, that yes, what
But
was
one
the
thing
issue.
what
Yes.
they have, what they have mentioned is that you need a separate cryo room. So that is a good part of this. That fine,
Yeah.
because otherwise we used to, in a small lab they
In
used
the
to give
small,
cryocan or
even
something.
even
So that
even
is a good part.
even it has been mentioned as a separate cryo containers for any disease specific patients which we are
Absolutely.
freezing within the liquid nitrogen. And
Okay.
one more thing, Nishad, you have mentioned about the alarm system. I think there was a publication, means it was in the ART rule published in March. It has been mentioned that a clinic must have a local alarm system which must be
It
an
has.
audible. Yeah,
It was there.
it was there, that it must be audible and it must be like in a reachable portion within a minutes of time. One embryologist should be there in the lab and it should rectify that particular situation which has happened. So, and later it was like it was removed as a must part having a local alarm
Yeah.
system. So according to you, what can be the means what types of alarms you can have in the lab, just to
Yeah.
just to
So
troubleshoot this situation?
right, for cryopreservation purposes, two basic alarms. One is your oxygen monitoring system. Because if anything falls, if the O2 level falls, there have been deaths because of liquid nitrogen, because it depletes the oxygen. So that's why your oxygen monitoring system is quintessential. You have to have that. Second is a basic monitoring system, as mentioned, like a ringer or a bell for the IVF center. But in case it's a daycare center, nobody's going to hear it. So in such centers, better to have a Wi-Fi system with an app where you can monitor the level of liquid nitrogen. And if anything goes wrong, the level goes down or there is a leak or something, immediately the embryologist and the clinician, at least 2 to 3 people, should have these apps per center, so that there is always a follow-up if anything goes wrong.
Yeah.
These are the basic things that are required.
Yeah, and there has been a few consents which were mentioned in the act as well, with the freezing of embryos, gametes, and there was a different consent by the name of a minor or an adolescent can freeze their gametes with the help of a parental consent. Pranay, can you please highlight on the consent part? Uh, what one must take care of filling the consent as per the latest guidelines what are being mentioned?
I think I'm just as in dark as anybody else in the audience, because I think at least now the part that the consent filling is necessary is being highlighted. So you mentioned the Form 11, which is for the adolescents and the young patients with the guardians. But are we still able to touch these without a proper per case basis permission? Because we have had to refuse a 16-year-old girl who had come for oocyte cryopreservation, and we had to tell her that we can't do that. Similarly, what we were routinely doing for oncofertility patients previously, 15, 16, 17, 18, 19-year-old males coming for semen banking for oncofertility, we are having to tell them that you are being put on hold unless until you can get a per case permission. So for me, Form 11 is very well intended, wherein we can actually have everything put in on paper, but I still don't think so that we can test these patients without consent, because without permission, because the age, we have to respect the age that has been put forth, 21 to 50 and so forth, whatever. So in the consent, basically the Form 9 and Form 10s have made our lives a lot easier, wherein we have actually passed the onus of having to call the patient on an annual basis Are you able to hear me?
Yes. Go ahead.
We are listening.
To get rid of that nagging thing that at the elapse of 12 months, we are the ones who have to call them. So it's now their responsibility that they will have to get in touch with us. And in case they change their contact details, and in case they're not interested in renewal, they'll have to let us know. Otherwise, we can very well discard these. The other thing is it is explicitly mentioning that the duration, and also that the payment is for one whole year, and no, there's no part payment. I mean, previously some patients do that 3 months, 6 months, and fortunately this consent gets rid of that patient nagging as well, if I may say so. So that being said, I think one category that was previously long before present, what we have discussed is embryos to be donated. That category has been
removed.
Yeah.
Ram, you want to add something in this?
Yeah, it is still little, only time will tell the how we go ahead as an individual clinic, and it's not only consent which we need to feel. No, when the young girl is coming for the fertility preservation, there are lots of things. So let's wait for down the lane, and what it is too early to comment that it is only in the act, it has the consent has given, it is enough. No, we have, there are lots of things, no, stimulation, pickup. How do we go ahead with all that?
And also, how long we have to keep gametes?
That is mentioned. That is 10
That
years.
is mentioned.
It is
It's 10 years.
10 years, yeah, but what
And
about
for
backup?
onco patients, we can freeze for more also.
You
If
have to
they
take the permission
their
from the national
permission.
board. You have to take the permission from the national board. If you are freezing the embryos for more than 10
More
years,
than
you have
10,
to go to
10
the
years. Yeah.
national board and say yes, you want to freeze. Then only you can do. Not for everyone.
According to me, these consent forms are now just not a piece of paper. It holds you responsible to the couple is also equally responsible, and the counseling has become really important in this. Like, before starting the procedure, I think in many of the clinics they start of the procedure and on 4th day, 5th day, 6th day, ले लेंगे consent का क्या है. So now all those things have been taken out.
So day one we have
अभी ऐसा नहीं राम, अभी ऐसा हुआ कि उनका सर्जिकल प्रोफाइल हुआ है कि नहीं कोई नहीं देखता, कंसर्न है कि नहीं.
Consent है कि नहीं? Yes.
Actually, now they have to take it prior to starting of the procedure. So that's really important. And also, there are few things which are very difficult to convey to the patient. Like when it comes to that, you have to patient has to sign after, like if any of the mishappening happens or something, who will be responsible, what to do with those embryos. So all those things are really important to explain. And that's where the counseling will become more and more important.
Okay.
Yes, Nishad.
Yeah. So it's about the 10 years thing, especially, okay, embryos, fine. What about the oocyte? Especially the longer the gap is, especially for the people who are going for fertility preservation. And there's a very interesting paper by Din et al. From South Korea. I think it's a very recent paper where they transferred for six patients. Obviously, the data sample is very less. And the transfer was done after 13, 14, 11 years in different patients. And they found that there was no pregnancy or pregnancy losses were there. So whether should we keep it for 10 years, whether the end result, that is also something which has to be discussed, which is not mentioned in any kind of law in anywhere in the world. Now research is coming that keeping it for more than 10 years, the results are not up to date. So this is something we should contemplate about.
I think with the consent, patient counseling should also be done meticulously. That this particular reason, they should not be with this particular mind thought.
That is what this is up to 10 years. They can take treatment before, but minimum 10 years you should keep.
Yeah.
What about the semen sample, backup semen sample?
That we throw it.
That is 45 days and the story is over.
So again,
That's
we have
fine.
to take a consent on it, but a short period. So that we have to mention on consent form. Is it?
Yeah.
Okay. The thing is that one more thing, actually liquid nitrogen, which with Nisha you said, okay, the alarm system. So in market, there are a very few alarm systems are available. Okay. And they are very expensive. And yes, people wanted that. So any other suggestion?
They're not expensive.
They're not that expensive. You will see the other. If you see the Indian products and the products from outside, there's a lot of difference in the cost, and they are equally reliable. I mean, like my experience has been, I think Pranay also can butt in. I think you've got the same system that I have.
I'm
So
using
it's been very good.
I can
Yeah,
name
same.
them. I don't mind. So
No,
they're expensive, and so they're not just level indicators. It's just not that the level of the liquid nitrogen will get depleted beyond a particular limit that they will buzz off. They're also vacuum breakage of vacuum indicators. So
yes,
before your liquid nitrogen level depletes, you will have the cryocan cooling, and they have surface temperature probes as well. So we did not wait for the thing, because in hindsight, we should have done this a lot earlier.
yeah.
Act or no act.
So is it a one monitor, one probe, or means multiple probe and one monitor?
So
that depends on how much money you have.
So it is an independent.
It's not about money. It's about that how it is
Multiple is
efficiency
available.
of
That's what I'm
the
saying.
machine.
You can
Yeah.
have multiple. You can have multiple probes.
So it's
No, multiple probe. That project was done, and it is not good. If you have only one done and you keep it multiple, it is not so. Basically, now it is 1-to-1.
That is what I mentioned. If you could, yeah, please, Pranesh, go ahead, please.
Cryocan. We are using for all our cryocans. So it's one probe per cryocan, and unlike the incubator alarms, wherein you have a central repository which monitors the incubators, you can have independent cryo alarms. So these are not they're independent. They're not linked to a central repository. So they're just connected to the Wi-Fi. And previously they used to offer just the level indicators, but now you have the surface probe alarms for the vacuum. So it is one per cryocan. This is the company that I'm using. I'm pretty sure there are others as well.
Yeah, that is almost all other are like same only, means same is maybe features wise and all that. That is different, but one alarm, one can.
Yeah, yeah.
And there has been a lot been discussed in the act regarding managing the records, means how to keep the records and how to keep the gametes under the cryopreserved conditions. So there has been discussed a few points regarding this. I think Charu ma'am, can you take this?
Yeah, see, Rahul, I don't know how many follow. I have seen one even clinic where they freeze sibling if the two device, then two cryocan. But how do that maintain? I haven't done. So one way it is good that if patient has a two device, if one cryocan has some kind of loss, at least one straw is saved. So that is one kind of thought they put in. But as long as the documentation part is concerned to keep the record, and it is very difficult because in tank one straw is there, in tank 8 another straw is there, and it is very difficult. But as long as all documentation part is concerned, we have to in our like depending upon our individual IVF clinics workload, we have to sit and make an SOP that how it is easy for each and everyone. It's not that if someone has frozen and if someone comes for the thaw, they should locate the the straw in the same canister, in the same can, in the. So in my practice, I write the color of the device, also color of the goblet. I don't do that. So everything is so clearly mentioned, and particularly when we are doing this cryo freezing, even the marker makes a difference. There are some markers, it says that, but in liquid nitrogen it will wash off. So we have to check that which marker pen you are using. And something are now barcoded are also coming, but that is also how far it is sticking. Sometimes it is even going with that. So we have to do lots of homework and set our SOP with clinic, irrespective of this. And this are we are doing for years. The law and everything now it is there, but we are following that for the documentation for many years. Plus, in my practice, wherever I freeze, I always write the patient's number and email ID, whatever it is. So it is handy. Sometimes if it is, it is so handy that we do not have to go into and check that what is there. And whenever patient is coming for the frozen thawed embryo transfer for, we write in the report that if they have any remaining embryos, what is the renewal time? And our software gives that alarm that now this patient, so automatically the phone call goes or the registered post goes that there's a time for the renewal. So there are lots of hard work of all the team member behind, means our team.
So, if I may add to the documentation, I think ma'am has just mentioned the cryopreservation, but explicitly in detail. I think we have a form 14B, which now we have to perhaps obligatorily fill and maintain, wherein we have to have tracking of each oocyte and its fate. So you have day 1, day 2, day 3, day 4, and day 5 assessments, and the cryopreservation record in this form 14B. So when you say documentation, this is just a minor part of it. Apart from the consents, form 14B, I'm not even talking about the third-party reproduction. An Excel sheet has to go down to the PNDT. Then an Excel sheet has to be of late. The PNDT has done away with the submission of the hard copies, and they say that maintain the hard copies at your end. And now they have provided another Excel sheet. So now at the month's end, we are sending across 2 Excel sheets. So this, and I'm pretty sure at the end of this ART body being set up, we'll have another way of having to obligatorily communicate our procedures and their outcomes to the ARD board as well. So it's humongous. I mean, you cannot, as an embryologist, think that you will be able to do clinical work and documentation. There's no possible way of not spending 12 hours in a day and getting done with it. So you need to have somebody who does this for you. Because if you, I am presuming at least the forms that I have in the latest gazette, they have to be obligatorily filled. So something like this form 14B, it's quite comprehensive, wherein you have to track every oocyte's outcome. So things have been made very difficult.
Yes, yes. And it has been already mentioned in the law as well that they can inspect, they can seek, they can ask you anytime, any day, and they can come and check anytime your records, what records you are maintaining and how you are maintaining with the law or with means whatever the format it is mentioned in the act as well. So the documentation is the key part for everyone to be on the safer side. So there was again this means in the ART rule which was published in March that there can be a possibility to use or to retrieve sperms posthumous, but the consent part has to be the key part in it. A patient should give a consent, and later on that particular thing, this particular procedure can be done. So any comments on this usage or this technique?
I'll be very honest, I have totally
I
disregarded
have no experience in this.
what was present in the previous.
It was just a portion in that this ART rule that this condition can happen or this condition may happen to any patient, any person, but there was a provision made by the government that this thing must be aware. We all must be aware of this thing, that there can be a chances of posthumous sperm retrieval. So
like who will have this
See,
courage to go and ask patient to fill
See,
this?
the details are not given only. I mean, let us see practically. Are you going to take the patient into your IVF OT to take out the sperms, first of all? And if you're going to do it in different OT, do you have 2 different OTs? Let us be practical about it. Nothing is mentioned. Just this 2 lines are mentioned. So that has to be some clarity has to be there. The government as well as the jury, the judiciary should be involved in this and then take the proper steps and then get it done. It's very vague actually when it this is mentioned. So it's very, it's a gray line. Whether are you going to do it? That is the question.
Rahul, can I add something?
Yeah, yes.
When we go to the bank, even now, we write the name of the nominee. If something happens to me, the bank account, whatever money is there, gonna be to that person. Right? So it is a very simple and a logical thing. Like, why can't we have a normal consent like this? Patient coming to us and we are storing the gametes of them. Why not? Can't we have this kind of consent? And make things very simple to everyone. That we have the consent. If you want, you can use it later on.
Yeah, not only the nominee part, now the consent is having a specific terms and condition where they are asking, in case a couple is not showing up to the clinic, what alternative contact they can provide, and the clinic can contact those alternative contact. Means it was there in this. Yeah, just a second.
Can I
Yeah,
add
this.
something?
Yes, ma'am.
Don't
Yes.
mind, I'm not a panelist, but
No, ma'am. Sure,
No,
sure.
ma'am, please.
Ma'am,
okay,
you are the mentor.
I mean, theoretically, even if you have got the consent for sperm retrieval posthumously, the thing is we need consent for each and every procedure. So you have retrieved the sperm if you want to do IUI or IVF, but then for embryo transfer again you need a separate consent, and that cannot be taken beforehand. So it is illegal to take consent for a procedure beforehand. So if there is this policy in your clinic that you get all the consent signed beforehand, and the patient has died much prior to the procedure, then that won't hold true. So embryo transfer cannot be performed even if there is a consent for retrieval of the sperm posthumously, or even for use of sperm for IUI or IVF purpose. So fertilization can be done, but no embryo transfer can be done.
Yeah, I think means the legal part is there, but I think the much difficult part is explaining this consent and getting this undersigned by a patient. That is again the toughest task which one can undergo. I also was amazed to see this this paper in this ART rule. So I
When I
think
was talking
we have.
about nominee is a completely different thing, and this is, I think, a completely different thing. When you talk about like nominee, already they have mentioned if freezing of embryos and all. Like if something happens to one partner, what should be done with the other embryos?
Yeah.
So I think again, yeah, again, Rahul said it is very difficult to put this paper in front of patient.
And getting that undersigned by that patient is again a difficult task. Means
Yeah.
explaining them that if anything happens to you, who will consider and who will think of it that something is going to happen. So
Yeah,
it's
Rahul,
it's like
I
it's like
completely
it's
disagree
like
here.
yeah.
Rahul, I
Yeah.
completely disagree. Yeah, we do it every day. When we go for the bank, we go for anywhere. It is there. If
Yeah,
something
yeah.
happens to you, this will happen. So why we have to be emotional here only?
No, it's
Just be
not it's
logically,
not
don't
an emotional part.
hey, don't be, don't
It's
be
a
emotional here that something happens. This can happen. We all don't know what will happen tomorrow to us, and we all are prepared for it. We all have LICs, policies with us. We invest for our futures, right? We all have health insurance with us. Why we have it? For the same reason, we don't know what will happen to me next day. I think I have a cover for it. The same cover is there in the consent.
Yeah.
But
So
actually, purposely, we don't know the rules and regulations right now. Okay. So what about the forms and all? Okay. Once we start practicing it, we will learn that each
yeah.
and every day. Is it?
Let's wait
So
for more clarity.
actually, more 2 3 months to go.
I think now the clarity will not be in the format of what we are doing or what we are expecting to do. The clarity will
The
only be
clarity
in the
will be
format of
how we
bodies
are
or the appropriate
proceeding. Yeah.
authorities are formed. Because
I
now
agree.
what they have means disclosed in that notification that the 17 remaining states are not yet formed with the bodies and appropriate authorities. So they are in the merge of making these bodies and authorities, and only after that the same thing will happen what is happened with the 11 states where the body is already formed. Means the inspection is about to begin. They'll be checking the clinics and giving away the certificate to the clinics. So I don't think or I may be wrong in this scene that any clarity is going to come up soon with the clause or with the opinions what we are having right now in our minds. So it's better to be means very clear with the law, to read the law properly and to work with the law.
So,
Be in the
Rahul, I
law.
want to add here because
Yeah.
recently the IFS had some votes with the national people, those who are there in the member, those who are member there, and the government is calling them for whatever changes you want in the act or the rules now. to come and tell us. They have a meeting recently, a day or two before only. So
I
probably
think it was not in the open public. It was
Yeah,
like
it is not
they
in
have.
open public.
but they're coming, but they're going to the society and they're asking it. If do you want changes, what kind of changes you want? And there are people from our own fraternity. They knows what we want. And
But
they're very welcome.
it's only when they are approaching them and they are asking that what changes you want. Means earlier it was a public opinion or a forum that you can add whatever you want to add and they'll consider your additions.
It
But
was
now it's
there,
like,
it
yeah,
was there, it was going very well, and then suddenly that erode episode happened and it has
Yeah,
collapsed.
Yes.
very true.
Because all the body, ISAR has their spokesperson there, even IFS, I know they were going and, have discussion. And then discussion went in between abruptly because of this erode episode. Maybe now it again, it will.
Even they have visited also, they had a meeting also. Okay, they have made changes. That's what the rules have changed. No, act has been changed twice or thrice. We don't know.
Something good will happen.
let's hope,
Yeah,
let's hope for the best
absolutely.
and keep
Everything
the fingers
happens for
crossed.
the
Actually,
everything
denying it.
happens
They
for
were
the
denying.
good only. No, I am very positive. See, such as beautiful changes everywhere, documentation or separate
That's good.
room or alarm
That's good.
system. Now, even no, recently we had a meeting with all embryologists here in Telangana, AP. And we had 110 embryologists coming because each and every day, otherwise 10 embryologists are calling us and asking कि what madam कैसे करना है क्या करना है बताओ. So we have arranged this, and Krishna Chaitanya is one of our state board member. We have one magistrate that how to go ahead with this metropolitan magistrate registration for this affidavit for the recipient cycles and all that, and it. So now everyone at least aware that what is the requirement and how do they have to proceed. Because majority of the thing, even when they have state form also, majority clinics, embryologist has only form filled up.
Yes. So I think with this we have came to an end of this panel discussion.
Thank you all panelists.
Can we have group pictures, Rahul?
Yeah,
Even.
sure.
Yes.
It's everyone in the camera. Yes.
Yes.
Clicked.
Nancy. Just one more click. Thank you.
Done.
Thank you.
It's a pleasure
Thank
being
you,
part of the
everyone.
panel, Rahul, Adita.
Yeah.
Wonderful panel. Yeah, we all
Thank
Yeah.
you all the panelists.
Wonderfully done,
After a
Rahul and
long time,
Vasudha.
after a long time, we have not seen each other.
It's wonderful
we-
to see all of you. Like really, it's been a long time, and you did a wonderful job, Rahul and Adita. Very nicely done.
Hopefully
And
we'll
we
meet,
really enjoyed the panel. Yeah.
Yeah.
we hopefully will meet each other in next month.
Yes, absolutely.
Yes,
Looking
we are
forward to
there
that.
in
Next month. And this month also we have a conference, I think. So
Yep.
probably we can,
Yeah.
if you can meet there, if you can meet in Delhi.
I think
Absolutely.
yeah, definitely that would be great.
But
We can
yes,
meet
are
both.
meeting. We all are meeting. So great.
It's
Right.
great to be part of it.
Okay. Have a good evening, everyone. Thank
Right.
you.
So
Bye
much.
bye.
Thank you very much.
Bye, ma'am. Bye, everyone.
Bye.
Bye-bye. Bye, Bindu madam. Bye, Charulata madam.
Bye, Bindu,
Bye,
ma'am.
Gaurav.
Bye, Adita. Bye, Charu sir.
Bye, everyone. See you
Take care. See
soon.
you. Bye bye. Yeah.
Good job.
Thank you to all the panelists.
Charu
and
sir, bye.
moderators.
Ved sir, bye.
Bye.
Charu sir, can you please give the vote of thanks?
Yes, definitely. I would like to. I was waiting to allow me for speaking. See, this was a wonderful discussion, and this ART bill and so many things has been discussed. What I came to know, I just want to share with you about this ART bill and how to go about. So the very first thing is that because this is law is there, so whatever changes, let them come. But you are supposed to follow this. That is one thing. There is no ifs and buts in that. Second thing which has been asked to me is this ART rule, that in ART rule ये तो लिखा ही नहीं है, पहले लिखा था. So the answer was that this ART rule, what they have come up, is only the changes which they thought and they put, and those changes are mentioned. Rest, if the thing is not mentioned, that means it is still there. So that is another very important aspect of it. It's ART rule means यदि उसमें नहीं लिखा है इसलिए नहीं होगा, ऐसा नहीं है. जो चीज नहीं लिखी है वो है, already है, ऐसा है. And the third important thing about this liquid nitrogen indicator, what we were discussing, I think the most important part is that availability of liquid nitrogen should be always ensured. यदि alarm लगा भी दिया और liquid nitrogen ही नहीं है तो क्या होने वाला है उसका? So because this has happened many times, and last moment availability is not there, then hiring from here and there, इधर उधर जा रहे हैं, मांग रहे हैं. So I think that is more important to have an sufficient storage of liquid nitrogen with us, so that in such situation at least we can manage something. So with this, I would like to thank all the participants. I would like to thank all our panelists and wonderful coordinators and moderators and all. And this should be an always ongoing process on platform of iHera. We'll come up with such more webinars soon. And I would like to announce here that we are soon coming up with our next conference of iHera Embark 3. That is supposed to be on 12th and 13th of November. So hope for the best, and see you all there on this Embark 3. So all the best, and thank you very much once again on behalf of iHera.
Thank you, sir.
Right, sir.
Thank you.
Nidhi, can we, Yoshita, can we stop this now?
Yes, sir.
Nancy, yes. Can we wind up?
Yes, sir. Yes, sir. Thank you, sir.
Okay, so see you all.
Okay, sir.
Okay,
I
sir.
think you can stop.
Bye bye. Sir, good night.
Okay. Bye. Good night. I think you can stop recording. You tell
Yes.
concerned person.